So we are going live on YouTube. I think there's some issue with the Facebook right now. So same YouTube Ulte FB is there. We are going live there.
But then the ULTOE group members can see it live on FB.
Share a post there, I guess.
Yeah, I'll share the post. We do for all the genitals
live on YouTube. I think there's some issue with the Facebook right now.
Okay, so we are live now.
So same YouTube Ulte FB is there. We are going live there.
Same link in YouTube.
The ULTOE group members can see it live on FB.
Share a post there, I guess.
Yeah, I'll share the post.
We do for all the genitals on YouTube. I think there's some issue with the Facebook right now.
Okay, so we are live now.
So same YouTube Ulte FB.
There is echoing of the voice.
Link in YouTube.
ULTOE group members can see it live on FB.
Share a post there, I guess.
Yeah, I'll share the post. We do for all the
Nitesh boss, just mute the live feed which you are watching on YouTube. I guess if somebody else is watching.
Yeah. Okay, we'll start now. Good morning, everyone. Sorry for the technical glitch. There was some glitch, so we are sharing the post on YouTube Ulte FB channel. Today, we are going to have a very nice debate on various aspects of PCNL, and we have got three experts with us who hardly need any introduction. Dr. Sabnis sir, who is the president-elect of Urological Society of India, and who hardly any introduction. He is a teacher par excellence, and who have guided many young urologists for his for PCNL and various other aspects. Dr. Pal sir, who have done many workshops on PCNL and who have trained more than probably a few 100,000 urologists how to do PCNL. And Madhusudan sir, who was also the president of Urological Society of India and who is also well known for his technique in PCNL and the ultrasound guided PCNL punctures. So we have got three experts with us, and we have got different talks on different aspects of PCNL. We know PCNL is one of the most common surgery, but still many the way people do PCNL surgery differs. So we are going to have some debate just to highlight the point why some technique scores over other, or why some people prefer that particular technique. So to start with the first talk is by Dr. Abhijit Patel, who is a consultant urologist at MPUH Nadia, and he'll be talking to us on ultrasound guided puncture. With me is also Dr. Harshawardhan Tanwar, who is from Ahmednagar, who will be moderating this session. Over to you, Dr. Abhijit.
Well, thank you, sir. Am I audible and visible?
Yes, Abhijit, you are audible and visible.
Okay. Well, at this outset, I would like to thank the ULTOE and Starper group for this wonderful debate. And I am speaking on ultrasound guided puncture. I have nothing to disclose. There are many advantages of an ultrasound guided puncture. Let's see one by one. So first is correct access to the kidney. By correct access, what they mean is that if you have an oblique puncture, or if you have a central or direct pelvic puncture, it may lead to bleeding and urinary extravasation. So what is an ideal puncture? It is a straight track from the skin to the cup of the calyx, leading to clear urine reflux, and the wire goes directly into the ureter or the upper calyx. Now, sometimes a straight path may be apparent, as can be seen on the left side of the image, but it may be actually a zigzag, as can be seen on the right side of the image. So an ultrasound guided puncture, when you start from medial to lateral, it helps you to know the posterior calyx is the first calyx that will come when you go from medial to lateral, and you can clearly see the cup of the calyx, the tip of the needle. It goes through the cup of the needle into the pelvic calyceal system, and then you can accurately puncture the calyx containing the stone. Now, why do I say a perfect puncture? This is a case with a stone in the anterior calyx. Now, fluoroscopy is a two-dimensional modality. So if you try to puncture through a skin point which is A, and then you try to puncture the posterior calyx, and now you come to know that the stone is in the anterior calyx. You would try to manipulate and get to the point to the anterior calyx, and now when you remove your needle, you would have a zigzag pathway, and this would sometimes lead to a something known as Bermuda triangle, which would lead to a point of kinking at point B. Now, when you try to dilate, there would be kinking of the glide wire in the path, and even if you have the expertise and dilate it, now what will happen when you dilate with an amplage sheath, you would have an point of torque at the skin side and a point of torque at the point B and the renal angle. And now there would be a zone of parenchymal tension which would lead to bleeding, and may lead to bleeding intraoperative as well as postoperative. Now what an ultrasound guided puncture do, it will help you to know the correctly the calyx containing the stone, a straight path, the wire goes from the skin into the calyx into the pelvic calyceal system. The other benefit is intrarenal vascular injury. So if you can add a Doppler to your B mode, you can avoid the vessels and very well get to the pelvic calyceal system without injuring the blood vessels. This is a randomized controlled trial which compares B mode versus Doppler and says that the Doppler mode significantly decreases the bleeding complication. Now this is again a comparative study comparing B mode versus Doppler, and it says that the Doppler avoids the real-time renal blood vessel during puncture and the incidence of bleeding complications. Yes, you can avoid the surrounding organ injuries by ultrasound guided puncture, especially the spleen on your left side and the liver and the colon on your right side. Now let's have a head-to-head comparison of ultrasound guided versus fluoroscopy puncture. This is a study done at our own center. The number of attempts required in ultrasound guided access 1.2 versus 1.14 fluoroscopy guided access, which was quite significant. The fluoroscopy time for puncture was 6.4 seconds in ultrasound guided versus 41.7 in fluoroscopy guided access, which was very significant. The transfusion rate was 2.02% in ultrasound guided access versus 6.6 in fluoroscopy guided access, which is also significant. This is a review article in Indian Journal of Urology which compares the different modalities of access like ultrasound versus fluoroscopy, and it says that color ultrasound avoids a vascular injury and decreases intraoperative as well as postoperative bleeding complication. Coming on to pregnancy, we have to avoid radiation. As you can see, this female requires a diversion, and you can see this, the complete procedure has been in ultrasound guided. You can see the needle, you can see the wire which is parked. Now we can see the dilatation of the kidney under complete ultrasound guidance, and soon we have inserted a PCN, and you can see the Malicot tip in the pelvic calyceal system very well completely under ultrasound guidance. And coming on to this paper which they have done, PCNL in a pregnant females, completely ultrasound guided. There's no fluoroscopy in it. Coming on to pediatric population, this study evaluated 30 children with completely fluoroscopy free ultrasound guided PCNL, and they could very well do in all the 30 patients. Radiation exposure. They are not only the pregnant ladies and children who are the only ones who deserve less radiation. Every one of us deserve less radiation. What this study says is that fluoroscopy screening leads to radiation exposure to the medical staff. Is the maximum radiation exposure being to the operating surgeon, mostly to the legs. The assistant received the less radiation exposure, and then the surgeon and the nurse did not receive significant amount. Now this is again a paper from a center which evaluates the factors affecting radiation exposure during PCNL procedures, and it says that the fluoroscopic access to PCS was found to increase the radiation exposure. Now this is a head-to-head comparison between completely fluoroscopic guided PCNL versus completely ultrasound guided PCNL, and the transfusion rate, as you can see, they were only 7% ultrasound guided versus 21.4 in PCNL fluoroscopy guided. And the ultrasound eliminates X-ray exposure to the surgeon operating staff, avoids radio contrast material, identify all the tissue from the skin to the kidney, and avoids the energy expenditure of the surgeon and the staff, as they don't have to wear a lead shield and other things. Now coming on to special situation, you can see this male, severe kyphocolitics male. Now the ultrasound would be a quite wonder for the puncture, and where you can very well have complete stone clearance in such a patient. Again, an ultrasound would be very useful in such a morbid obese female, where you can access the distance between the skin and the kidney. Supine PCNL, more and more done nowadays. Ultrasound guided is really a very useful tool for puncturing in supine PCNL and also in anomalous kidneys like Harshawardhan kidney. Now this is a pelvic stone. Now on actually we came to know it is a pelvic stone in a ectopic kidney. Now when you do an you can there will be bowels which would be interposing between the skin and the kidney, but when ultrasound got in a special position, the balls would be dropping on the opposite side, and we can clearly see the tip of the kidney, and there is no interposing bowel. You can properly hit the lower calyx, and you can clearly see the clear efflux of the urine which is coming out. Again, in transplant kidneys, ultrasound guided access is really a boon. So to conclude, ultrasound guided access reduces radiation exposure to the patient and as well as to the operating personnel, which are us. Accurate access to the desired calyx, especially the calyx containing the stone. It avoids injury to adjacent visceral organs and also to intrarenal vessels. In case of unsuccessful retrograde ureteral catheterization, there would be some moments where you cannot retrogradely catheterize the ureter. Ultrasound guided puncture is a boon. In pregnant and pediatric females patients where you don't want radiation exposure, ultrasound guided is a useful modality. Also useful in supine PCNL and anomalous kidneys and transplant kidney access. Well, thanks. Meet you again at the rebuttal.
That was excellent talk, Dr. Abhijit. And it was a perfect opening for a wonderful debate session which we are having today. The next speaker is Dr. Ravi, who is poet by heart and well known for his innovative way and introduction of some character in his talk. Dr. Ravi for CM guided puncture.
Good morning, sir. Am I visible and audible?
Yes, you are. Please go ahead.
Okay. Good morning, everybody. Thank you, Alto. Thank you, Nitesh, sir. Thank you, staffers, and everybody listening and giving me this opportunity to fight tooth and nail against my friend, Dr. Abhijit, for protecting and safeguarding CM guided puncture in PCNL. Friends, PCNL, the success depends on initial puncture, the success depends on successful dilatation and a successful lithotripsy. And as we all know, the most important part of PCNL is a successful initial puncture, like puncturing through Arjun's vision. And friends, fluoroscopy is the only modality which can give me an Arjun's vision, which can help me puncture the desired calyx, cup of the calyx. Such a picture is not possible with the help of ultrasound. PCNL is the shortest and the straightest track is visible only with fluoroscopy. Why fluoroscopy? Because it gives me a perfect anatomical delineation of all the anterior and the posterior calyces, minor calyces. It gives me 3D orientation. Friends, this is written in Campbell Urology that it gives 3D orientation. And the most important part is it is ability to monitor all the steps of the surgery. So why fluoroscopy? Fluoroscopy is the modality which helps me know, help in intraoperative planning. I can know about the infundibulum width, which calyx is accessible through which calyx. The 3D orientation of direction of puncture, trajectory of the track, and the depth of puncture track is possible only with fluoroscopy. Such punctures, such cases with Stagon stones, difficult punctures, intraoperative planning is possible only with fluoroscopy. I can present such images on webinars and other platforms and can discuss with the colleagues, which is not possible with the help of ultrasound. Why fluoroscopy? Because of the familiarity, of the training and experience everybody has, and of the availability. I would like to know about all the friends who are present in the audience, that most of them would be attached to either an institute or a private practice or a medical college. And how many of them are familiar, trained and expert and have available ultrasound in their setups? Ultrasound guided punctures with and without puncture guide. I'd like to ask my friend if he does a completely USO guided puncture PCNL, then I would be happy. But if he says that he performs rest of the procedure, including the amplifiers under fluoroscopy, then he is defeating the purpose of ultrasound. So if my friend says I do completely USO guided PCNL, I really doubt daya kuch to gadbad hai. So if only the initial puncture, which in expert hands requires 2 or 3 radiation exposures, and rest of the surgery like dilatation, like stone clearance, how would my friend confirm a stone clearance on ultrasound? It is not possible. And nephrostomy placement and degestin placement is also with the fluoroscopy. So it is actually a fluoroless procedure or a less fluoro procedure. I would like to ask my friend. Ultrasound guided punctures without a needle guide. My friend has shown all the images where he has used a needle guide. I would like to know if most of the centers really have a needle guide, and without using ultrasound without a needle guide is defeating the advantage of the ultrasound and it has the same risk of visceral injury, which is in fluoroscopy. So radiation safety, yes, we all have to be concerned and worried about it. But friends, a little knowledge is a dangerous thing. It is, if we go to the literature, the annual radiation exposure recommended is less than 50 millisieverts. And this is the paper from MPH itself, which clearly says that the radiation exposure levels, even at high volume centers, are within the safety limits. So what is lacking? Is it the lack of radiation protection? No, it is knowledge of radiation protection and the absence of training, which actually predisposes us to the radiation risk. So yes, what we all have to be worried about, we have to be aware about the LRA principles, and we have to don our radiation lead aprons properly. So either we do it fluoro guided or we do it ultrasound guided. The success of the surgery finally depends on the urologist experience, expertise, and not the technique itself. So ultrasound guided puncture, my friend will say that he has got higher stone clearance, but there is no difference in the stone free rate in both the groups. And about the complications, there is no difference in the complications. The papers he has quoted are way back in 2010, whereas these are the recent papers of 2017, showing there is no clear-cut difference in the Levin window classification and blood transfusion and all other post-operative complications. Ultrasound guided PCNL, friends, there are residual stones even after ultrasound guided PCNL. And the problems with the ultrasound, I would like to ask my friend, in non-dilated systems, where will he conduct? It is not possible to identify a system which is collapsed. And how does he access the guide wire? By chance the guide wire gets kinked, such information is not available on the ultrasound. So, and the most important thing, why ultrasound machine is not available in most of the setups, it is because of the PCPNDT Act, which everybody is worried of. Any mistake by the radiologist or the urologist doesn't help us escape. So, is USG guided PCNL completely safe? I'm sure my friend will not have an answer to this, and he would like to get back to me later. So USG guided PCNL also is not safe. There are reported cases of bleeding, of pleural injury, and the stone free rates are just comparable to the fluoro guided punctures. Supine PCNL, my friend has said, but these are the papers, recent papers, where it is clearly shown that even in ultrasound and fluoro guided punctures, there is no difference in the success rate and in the complications. Special situations, a patient with nephrocalcinosis, how will my friend be able to know whether this is a residual stone or it is a nephrocalcinosis just on the basis of ultrasound? Only an RGP will help us understand these things. With stones with upper aortic kink, when RIRS is not possible and we have to go from above, we're using the flexible nephroscope. Without a contrast pyelogram, how will we be able to identify the ureteric kink? Special situations, horseshoe kidneys, these are the cases where we have successfully done with the help of CM guided puncture, kyphoscoliosis, even these cases. And pelvic ectopic kidneys have also been successfully done at many centers. So, see the bath, no bakwas. Fluoroscopy is the modality of choice because I'm trained in it, I'm expert in it. It is available most of the centers. It guarantees me a successful PCNL. And yes, friends, it is safe. Thank you.
Was a wonderful talk, Dr. Ravi. So Dr. Abhijit is not going to sit backward and he is going to come with a strong rebuttal.
Well, thank you. Welcome again for the rebuttal, which literally means no, you're wrong. And let me remind my friend the topic of discussion is puncture and the access of the kidney. It has nothing to do about the complete procedure of the kidney, of the PCNL. Well, the objection of my friend would be the learning curve, availability, price of the ultrasound guided. This is a paper which compares the learning curve of fluoroscopy guided puncture. It is around 50 cases. This is an article in Journal of Endocrinology. It assesses the learning curve for ultrasound guided puncture is only 20 cases. Now, this he tells me about the old papers. This is a contemporary review of ultrasound guided access in PCNL. And what does it say? Is that ultrasound guided puncture leads to decreased bleeding, less need for transfusion, slightly higher stone free rates than conventional follow guided access. It reduces the overall cost of the procedure by 30%. And it can be safely learned by all endourologists by only 20 procedures. Well, he says fluoroscopy may still be required for tract dilatation. This is a paper in which they have done all the steps of PCNL ultrasound guided. And mind you, we have also done it, but we are yet to publish that data. But this paper says 357 patients completely done under ultrasound guided. And well, if the access is a problem in an undilated system, you have a ureteric catheter, you can just inject some amount of saline and you can very well see the pelvic cholesterol system and have access. Well, coming down to the cost, I just asked Google, what is the cost of ultrasound machine price in India? And it says anything from 50,000 to 3 lakh. And majority of the centers now have ultrasound. So an urologist can always have ultrasound machine to have an access. Well, this is a simple pelvic stone for my friend. And by his expert fluoroscopy guided puncture, he would just puncture it. But mind you, it is not a stone. It is a nightmare for my friend. It is a calcified aneurysm in the renal artery. And I don't want my friend to be in such situation. Had he used an ultrasound, he would have seen there is a aneurysm over there, and he would have just deferred the case. So to tell is the ultrasound guided puncture is something like this, where you do every procedure under vision as against to fluoroscopy guided puncture, which is something like this, and then you can see what happens. So to sum up, I don't want me and my patient to have radiation exposure, less radiation exposure, don't want my kidneys to bleed like this, don't want surrounding organ injuries to my patients. I want something modality which is safe in pediatric population as well as pediatric pregnant patients, and would be a help to me in anomalous kidneys like Harshawardhan kidney, ectopic kidney, and transplant kidney. And to tell my friend, ultrasound guided Doppler puncture is something like this to miss the blood vessels and hit the target right at the point. And well, I can help and train my friend in ultrasound guided punctures and have multiple stone clearance at the same time. Well, thanks for this age-old technique of image guided puncture.
Over to you, Dr. Ravi.
Yes, sir. Thank you, everybody, and thank you, Dr. Abhijit, and giving me this opportunity to fight against you. And I want to really ask all the audience sitting over there whether they want to be theoretical or they want to be practical, like Ranchurdas Chanchad in this case. And because I'm sure more than 95% of the people sitting in the audience do a CM guided puncture. So if 95% of the people are doing it, how can it be so wrong? And any principle of stone surgery first do no harm, and the surgery has to be safe, effective, and available. And it has to be based on the evidence, the surgeon who practices on his experience and a good expertise. And if I go to the evidence, the recent paper 2021 Journal of Endourology, which clearly says that there is no difference between the fluoroscopic guided access and ultrasound guided access PCNL, and the choice of puncture depends on the surgeon's expertise in a particular technique and the patient and stone characteristics. Friends, why Siam? Because it is effective. Most importantly, it is available. I really doubt how many centers have an ultrasound, and especially with the puncture guide. I really would like to know the data if it is really available. And another important, the most important is the expert of the surgeon in the particular technique. The problems with ultrasound is the technical difficulty in a non-dilated system. As my friend said, that there was a case of aneurysm that would be easily picked up on a contrast pyelogram rather than an ultrasound, which if can be missed. Importantly, operator skill and training. Where are the ultrasound machines available for training? I really doubt, even if they are available at academic centers and at the medical colleges. Guide wire manipulation is the lifeline in urology and in PCNL, and that cannot be accessed with the help of ultrasound. And the availability and the PCP and detect. Friends, it is not that you have used a machine in your hospital and you can just fetch it up in the OT. You need to have specific permissions for shifting the ultrasound machine, for using it, and you need a proper documentation. So if I'm the Arjun of this case, Arjun, friends, be it the age-old Mahabharata or be it today's Mahabharata, it is the Siam, it is a fluoroscopy which will work as my Krishna, which will help me steer my chariot against any PC, against any stone, and lead me to the success. So thank you for all your attention, and I hope I have not bored all of you on a Sunday morning. Thank you.
Well, that was a perfect start for the debate session on PCNL. Now we have got three experts, Dr. Sabnis sir, Pal sir, and Madhu sir. And I will ask I know he does most of his puncture guided. What is your view on this, Madhu sir?
Well, you can call it a bias, but you can understand that I was among the first people in this country And I was trained for this by none other than Dr. Mahesh Desai to start ultrasound guided puncture. So I learned it from him and took on ultrasound guided puncture for my own cases, as well as to train as many people as I could. And I am convinced, of course, that it is a useful adjunct. There is no debate, or I would say there is no fight. Ultrasound is not a replacement to fluoroscopy. Ultrasound is an adjunct to fluoroscopy. So together, the two of them are the answer. I think that is, and the only other thing I would like to add is, it is not the question of what people in India are doing. The question is what the people all over the world are doing. And you would realize that most of the places where PCNL is being done all over the world, the people are shifting to ultrasound guided puncture. In China, in Europe, in US, everywhere, the first choice is ultrasound guided puncture, with, of course, fluoroscopy after the initial puncture and for confirmation of the initial puncture. I'd like to hear from Dr. Sabnis, who I know is also another student of Dr. Desai and proponent of ultrasound, and of course, Dr. Pal, who does not believe in ultrasound. So we actually have very clear lines drawn on this.
Pal sir, what is your view?
No, I appreciate comments of Dr. Madhu. Not that I am totally against it now. The use is increasing, but as everybody has very rightly said, it is just an adjunct. And as Ravi has very rightly pointed out, it will only save your first 6 seconds, and it will be only reducing the radiation by 6 seconds. When you make the puncture, as Abhijit has said, in 6 seconds you can make the puncture by ultrasound. The best point which I feel about using fluoroscopy is that my both hands are free while operating. So even if one needle is pushing in or when I am pushing one dilator, the other hand is also free to manipulate and help me other way. In ultrasound, your one hand is always occupied with the ultrasound probe. This is one thing, it always hampers my free movement. Secondly, the whole procedure like antegrade stenting and movement of the guide wire can very well be seen by fluoroscopy. Only what Abhijit has shown, once in a while, let me say once in a while, in a nicely dilated system, you can see the movement of the guide wire going in very freely, and a person who is not so familiar with ultrasound can also see it. Regarding this calcified aneurysm, even a person like me will identify calcified aneurysm as a stone only, because it will give me a lot of echo, and I may puncture even if the ultrasound is there in my hand. So these are the limitations of ultrasound. I know only one hospital in China which is not using fluoroscopy machine inside the operation theater for PCNL. Only one hospital. Rest 357 patients are being celebrated and they are being published, but more than lakhs of patients are not being mentioned about which are being used by fluoroscopy. So fluoroscopy is a must so far. Ultrasound is definitely picking up. We should learn it, but it cannot substitute the fluoroscopy at present. Thank you.
Sabnis sir, what is your remark?
Yes.
Without bias.
Yeah, I'm not giving any bias. I think both debaters have done a wonderful job. And in fact, I was initially thinking that the bias, I think the balance will definitely tilt towards the ultrasound, but I think Ravi Jain has defended it quite well. Well, there are, if you have to give really opinion without any bias, there is definitely advantage of ultrasound, because, and in fact, the point which is highlighted again and again, that it is very difficult to learn. Actually, it is opposite. People, we know that residents who come within 15 days, they get used to ultrasound so much that doing puncture, once you understand in ultrasound, is much easier. You don't have to understand and imagine the AP view, lateral view, 30 degree, anterior, posterior, side, this, that, nothing. You just see the calyx and puncture attachment will do the job. It becomes very, very simple. So actually, learning wise, ultrasound guide is extremely easy. However, there are definitely disadvantages or there are limitations, especially when the kidney is high and there are crowded ribs. It is difficult for you to do ultrasound guided puncture. You need to resort to fluoroscopy because rib shadows will come in the way. And subsequent punctures, if at all you want to require a puncture subsequently, it is very difficult because when water goes in, the whole interface is completely gone, and subsequent punctures have to be ultrasound guided. All the time we were misled or thinking that it is a full PCNL ultrasound guided, which I am also not in favor at all. It is only from China. The papers are published. We have tried. We have done few cases, but there are certain problems which keep coming. The topic only was of the puncture of the ultrasound guided. And I think the ultrasound guided also requires little bit of a fluoro adjustment. So we should not be adamant that it is totally ultrasound guided puncture. As rightly said by everybody, it is the adjunct to the this, and eventually ultrasound and fluoro both will work. What is important is a perfect puncture. That's it.
So that was perfect word of wisdom from three experts. Now we'll go to the next topic, which is on puncture. Whether we should do a biplanar puncture or a monoplanar puncture. We have got two experts with us, Dr. Harbi, who is from Philippines, well known for his expertise in PCNL, who will be talking to us about biplanar puncture. Over to you, Dr. Harbi.
Just a moment, I will interrupt here. Sir, can I ask everyone to please switch off the video modes, because I'm on my hotspot and I won't be able to get that connection. If everybody switches off, it will be nice. And I'm thankful to Dr. Pal sir for introduction of Dr. Harmi to all of us. He is a gem of a person and is becoming a very good friend of all of us. We welcome Dr. Harmi from Philippines.
Thank you, Harsha. Thank you for that. And it's good for me that you're having problem with your hotspot. I'm just kidding. Just kidding. Well, again, I'd like to thank you and all the organizer of this virtual meet. Hi, special hi to Dr. Pal, Dr. Madhu, and Dr. Sabine. Okay, I know I've met you in the PERCON already. To the others experts, hi again. I hope I'll be able to do justice in what I'm going to share right now. I'm just gonna share my experience doing a biplanar access. So we know that fluoroscopy guided percutaneous renal access done in prone and in supine. Okay, in prone usually it's done through monoplanar or in biplanar. In the biplanar, okay, it can be through bullseye, triangulation technique, and the hybrid. Well, I added the technique, the gradual descent technique in the biplanar one. So for the bullseye, we know that the C-arm is perpendicular or at 0 degrees, and you identify which calyx to be punctured. Okay, the C-arm then is rotated 30 degrees towards the surgeon, and here you determine where is the skin puncture will be made at site. Okay, such as this one. This is one of my residents who is using a hemostat so that the hands is free from radiation. Okay, you will have to more or less adjust the needle, okay, or the C-arm to position that and to get that bullseye appearance in your image. So the advantages is the site of the skin puncture is determined. The angle of the puncture is also determined with a single rotation of the C-arm. This technique is very easy to learn, and it has been time tested. It's been there for decades. However, there are disadvantages, such that if when you're targeting a midpole, it's easy to get the puncture site. It's towards the calyx, the center of the calyx, and probably if you have a pelvic stone, you'll be able to get it. However, the problem arises if you're going to have an upper or lower pole calyx puncture. Okay, this can lead to torque and can damage the parenchyma, okay, and lead to bleeding, thus decreasing the chance of complete stone clearance. It is more difficult in post-open cases since the kidney will be fixed, adding to more torque on the kidney. So how about the triangulation technique? Well, triangulation calyx is marked on skin using C-arm 0 at 30 degrees, the two known points, okay, and making an equilateral triangle targeting it to be aligned in the infundibulum. Okay, here the C-arm is rotated 30 degrees caudally or cranially, depending on which axis, what point, either the upper or the lower pole you're accessing. Advantage is that the depth of advancement of the needle can be monitored continuously using the C-arm in oblique position. Passage on rigid instrument is aligned, so there is less torque and less renal parenchymal problems. Okay, better maneuverability of the pelvicoileal system also. However, the learning curve in doing this is a little bit harder compared to a bullseye technique. These are the papers that will compare that both the triangulation and the bullseye technique is similar, and neither has a clear advantage over the other, except the triangulation technique has lower blood loss. So about our technique, I borrowed this from Dr. S.K. Pal. Okay, it's also like a biplanar principle using 0 degree or medial lateral direction and a 30 towards direction of the surgeon for the depth. Okay, this is one actual case I did. This is where I approach my access. Okay, if you're going to do a bullseye technique, definitely you're going to target through here. So you have to move around 2.5 to 3 centimeter above and target so that it will be in the axis of the kidney. So this is my preliminary scanning of the site where I'm going to puncture and more or less identifying if it's too deep or not. This is actually my actual puncture. So the question of radiation is that my kidney is far away. It's not seen in the field. Okay, and this puncture already only took me around 8 to 10 seconds, and that's it. Okay, the reason why it took longer because I have some residents with me, and I'm showing them this video. So to check if you are in your right position in the calyx, you really want to target, okay, one can again do and check, do a 0 to 30 degree angulation again, such as this one. Okay, so telling me that I'm in the right puncture site where I want to be. So the advantages, okay, hands away from the radiation, good pelvicoileal visibility. As you can see in this video, I can see all. Coming from above, I can see all the superior pole calyxes. Okay, less torque. I'm not torquing my nephroscope too much. The ureter is on the right side. This is the lower pole. Okay, and here's the mid pole. There. It's a little bit folded. Okay. However, again, this is not as easy as bullseye technique as I have described. Okay, you need at least some mentoring in doing this technique. This is a table lifted from the analytical review done by Dr. Sharma, all right, and published in your journal Urology. Okay, it's a comparison of the different techniques. Okay, as you can see in the bullseye and the triangulation technique, the determining of the site and skin puncture, angle and puncture, and the depth is more or less described on how you're going to achieve it. But if you're going to look at the monoplanar, well, this will tell you that everything has to be by experience. So if comparing them to monoplanar, well, monoplanar will be a little bit tough to teach to a urologist. Okay, here's a study done by Dede et al. Supporting monoplanar to be safe and that it has some advantages in decreasing the puncture time and minimizes the surgeon's direct exposure to the radiation. Our data support that, that's what they state. However, in the same paper by Dr. Sharma, okay, he noticed that this study comes from a group which had published the study on monoplanar access, and hence the bias and experience and expertise of these doctors with their own technique could have reflected in their result. Now, with the question of radiation advantage, as was mentioned by Dr. Ravi a while ago, okay, this study by Dr. Kumar showed that the exposure of the urologist's fingers were between around 0.28 to 0.35 millisievert. Okay, even less in what Dr. Ravi have showed. Okay, and the ICRP report, ICRP, radiation protection 60 report states that the annual dose limit to these extremities can be limited to 500 millisieverts. So that's the limitation. So even if you're performing 1,000 PCNL a year, you wouldn't be exceeding this limit. So it's basically safe and it's not that dangerous, especially for the young and novice. But yes, I still agree with the rule of Alara principle. So for the young ones, this is what I'm telling you. No, it has been reported that a novice urologist may achieve competency after 60 cases. Okay, but the excellence can be achieved only after 115 cases. So if you're going to sum it up, the exposure probably will not be really that high in getting this. That's why I advise for you to start with this conclusion by Dr. El Shebni in 2010, that the step-by-step advancement of the needle is a simple, accurate way to gain access to the desired calyx in doing PCNL. Rapid, successful puncture increases self-confidence, thus sparing them from frustrations that they might have after repeated failure to gain access in the kidney. As a takeaway, access is the key in doing good PCNL, and all techniques have their merits and flaws. Even until now, there is no general consensus on which is best. Okay, but I always try to aim for the access that will bring me the major stone burden, or that I can get a higher stone clearance. Okay, please continue to be eager to learn, and have a good mentor if you want to improve yourself. Okay, master one technique that you will be comfortable with, and then learn others so that you can be a versatile urologist. Learn to combine all these techniques eventually. As the football athlete Roger Staubach has said, confidence is the result of hours, days, and weeks and years of constant work and dedication. So puncture away. Thank you.
That was excellent talk, Dr. Harmi. And Dr. Harshawardhan will be telling us about monoplanar. Dr. Harshawardhan is a young dynamic urologist from Ahmednagar, who is also the admin of his WhatsApp group, Star Park, with whom we have associated with today. In that group, there are close to around 100 urologists from different parts of the globe who are mastering the business of PCNL. So we'll be talking, he'll be speaking to us about monoplanar puncture. Over to you, Dr. Harshawardhan.
So am I visible and audible?
Yes, perfect. Please go ahead.
Okay, fine. So at the outset, I want to thank first of all our chairpersons for accepting the invitation and guiding us through this debate. And I would like to congratulate Dr. Harmi for a very modest presentation on the puncture technique. Let it be a bipolar or a triangulation or a monoplanar. I congratulate him first. I will start my debate. So PCNL is a game of judgments. Judgment is a word that starts right from the day we start walking in our childhood. Judgment is while we drive. Judgment is while we swim. So once you have a judgment of doing things, the game seems to be easy. It has to be fit in your mind. What are you going to do? Slowly and steadily, you judge and you start doing things perfectly. So till date, as Dr. Harmi has already told, that till date, there is no puncture technique which is ideal in PCNL. But our aim should be safety first with zero accidents. Yes, then do it with any technique. Let it be triangulation, let it be biplanar, bullseye, gradual descent, or the monoplanar technique. Our aim is zero accidents and safety first. He has already shown this slide where we can get the techniques of doing a prone PCNL. These are monoplanar, biplanar, bullseye, triangulation, and hybrid. So what is an ideal access technique? So there are two factors in ideal access technique. First are the anatomical factors. It should be from the posterolateral position through the renal parenchyma towards the center of the calyx posterolaterally and towards the center of the renal pelvis. So these points should be there when you are puncturing a kidney for PCNL. Next it should be less time consuming, less fluoroscopy time and exposure, less torque while maneuvering the nephroscope, minimal complications, maximum stone load clearance, easily reproducible and versatile, and there should be a small learning curve. So what is a monoplanar technique? Monoplanar technique that is different from other methods in that it uses only fluoroscopic projections maintained on a vertical plane. Here you don't have to play with the C-arm and do the various juggleries to get an accurate puncture. The C-arm is fixed in a 0 degree, angulation of the IP needle from skin surface to the desired calyx, and calculation of the depth from skin to desired calyx. So these are the highlights of a monoplanar technique: angle orientation and depth perception. So does technique matters? Yes, a technique which is having less time, less radiation, less complication, easy learning should be what we could learn. So this is a video showing a well-known biplanar triangulation or hybrid techniques. While doing a PCNL, it takes a lot of time. And then when we learn the monoplanar technique, it becomes very easy for us to catch the stones and get rid of them. So this is the technique which can be done very quickly and with some innovative ways. This video shows how easily a monoplanar can go in and come out. So earlier we used to say that time is money, but since what Corona has taught us, time is not money, but time is for our family. So every time what you save in your OT can be spent with your loved ones. So the operative time, you can see a nice picture, a nice comparative study between the monoplanar and biplanar access techniques for PCNL. The operative time in the monoplanar group and the biplanar group, you can see the puncture time, there is a statistical difference that the puncture time needed in the monoplanar technique is far less than the biplanar technique. I will show you a video where I'm doing a superior calyx puncture, and within 8 to 10 seconds, I'm inside the kidney. Hardly it takes the time to reach the desired fluoroscopy is being used. And once it is done, we remove the stellate to confirm our puncture.
We have taken intracostal puncture in the superior calyx.
With only 4 seconds of fluoroscopy, we are able to puncture the desired calyx. So play radiation free. Why to expose ourselves, our hands to radiation? There is another study which compares the monoplanar access technique for the PCNL. Here you can see that there is a statistical difference between the exposure fluoroscopy time in a monoplanar group and the biplanar group. So less the radiation, more you are safe. I will show you how biplanar punctures can cause radiation exposures to your eye.
Then the CM was rotated 30 degrees towards
in
the
30 degree.
operating surgeon.
You can see the exposure to the hand because
using the
you come
bullseye technique
in the field of the radiation while doing a 30 degree bullseye technique puncture. I know it's less, but then
calyx.
Still why to go for it? The aims should be safety first. When you compare the complication rates between a biplanar and monoplanar technique, you can see there is no statistical difference between both the groups. So one can easily say that monoplanar technique is as safe as the biplanar technique, and there is no increased risk of any complications or bowel injuries when you're going for a monoplanar technique. In this case, I've taken a puncture in a monoplanar technique and see how nicely I can roam around the kidney without any torque or any blood loss happening during the PCNL. We can access all the calyces nicely.
Move our scope towards the superior calyx.
There is no hematuria or no blood loss happening in monoplanar technique also.
Thank you very
Coming
much.
to the versatility, let it be a narrow infundibulum calyx, let it be the superior calyx, or you have to take multiple punctures. It can save a lot of time and radiation exposure if you learn the monoplanar technique, which is the game of judgments. Here you can see multiple punctures are being done for the stone load, which is there in every calyx, and it's almost a tri-feed system. With monoplanar technique, as I've already told, that taking punctures is a can safely be done. As you can see in this case, we have taken almost 3 punctures. It was a diverticular stone here. Still, when we remove, there is no risk of bleeding, which is the most dangerous complication of a PCNL.
You can see this was the middle calyxial puncture. This is the inferior calyx puncture.
So you can,
and
after puncturing, you can easily remove it. We can do nephrostomy free PCNLs while doing a monoplanar
all the stones. I put a DJ. I am removing the.
So you can see easily we have removed all the dilators. When it comes to an ectopic kidney,
these are the CT scan images showing the left crossed
technique.
ectopic
In this
kidney
case,
with a
it was a pelvic ectopic
excretory
kidney.
blood loss, fluid
So this was the
extravasation
RGP
in the
image
figure.
showing here. We used a
And a
monoplanar
prone
technique.
RGP
Again,
was done.
we can judge the depth of the calyx and the angle orientation. So we are doing
We
a
infused
monoplanar technique
2
puncture. You
cc
can see
air
clear
calyx.
aspirate
What we do,
which was done. Even in monoplanar,
in the very first go, we
some
were
will
able
say that there might
directly
be a torque,
walked
but you
into
can
the
see the
ureter.
wire going straight into the ureter. So what does our data say? We
Wire
have done
into the
till
ureter.
now 3,345 PCNLs, both mini and standard, done with monoplanar technique and a single step dilatation. Had abnormal anatomies like ectopic and Harshawardhan anteriorly rotated kidneys. Multiple tract dilatations were needed in 1,802 patients. Only 2 patients needed blood transfusions, and there was no incidence of bowel injury or other internal organ injury. One patient had AV malformation. With monoplanar technique, one can easily say that the bowel is not injured, because in monoplanar technique we tend to come too medially to puncture the desired calyx. So no ideal way to do monoplanar punctures. It is perception what matters. Every case is different. One has to orient accordingly. So in monoplanar, we have to use the power of imagination, which will take us to infinity. Thank you very much.
Well, that was an excellent talk, Dr. Harsha. And let us see how Dr. Harmi is going to defend his technique biplanar. Dr. Harmi.
Yes. With regards to that, I already told Arsha was not able to prepare a rebuttal slides because I believe that what I have already stated in the previous slides, that it supports my belief that. But we're talking about the junior urologist who is joining us, and this summit is for also. That if they want to start, they should start with biplanar, since it's stepwise described. The technique is well described, unlike a monoplanar. I have to admit that I am actually also doing already monoplanar because I've already gained enough confidence, and I've already know I can feel the technique. I can feel the different layers of the skin going to the kidney. That's one part that you should learn in doing monoplanar. But for the beginners, okay, I still believe that a lot of them should do a biplanar technique, which they should be guided in how they're going to increase their experiences in doing the puncture. Because yes, if you have a lot of this and you missed it, frustration will set in and will turn you away from doing the procedure. So, and I think with regards to the safety and the exposure of the hand in doing a bullseye, that's the reason why at the very onset of the procedure, it is said that you should use a hemostat, okay? And in advancing the needle, you should stop the fluoroscopy so you can have there you play a little imagination on how deep you're going in. You rotate it to 30 degrees, just a spot film. Don't have to make it continuous, so you know that how deep you are. Okay, the most important thing is the last 1 centimeter of the puncture, wherein you're really there already in the calyx. So if you're gonna do it right, you do it right. You protect yourself, wear your aprons, wear your goggles, wear your thyroid shields, and all that. And a lot of this talk about radiation will be decreased. So that's all. Back to you, Harsha, and thank you. A very nice presentation, Harsha. Thank you.
Thank you, sir. Thank you. So I will go with my rebuttal slides. So we have a very beautiful mind which God has given us, and with the knowledge in it, like Abhijit and Ravi has already told about the anatomy. If you have the anatomy, and of course we are going to, everyone has it, so use it. We can analyze the depth what we are going in. We can orient our angles, and yes, the most important thing in a monoplanar technique is the hand-eye skills. Hand-eye coordination is the most important thing. So with the correct knowledge, we can do the monoplanar technique punctures easily. To tell everyone that we already have learned in our department to start with monoplanar techniques only, so that every case you can do it. No case you are afraid to go ahead. Let it be the stagons, let it be the non-dilated systems. With once you know how to judge the depth and orient the angles, you can do any case in PCNL. So this is a beautiful video showing how fast the human brains can learn and how fast they can analyze the depth and the angles. So this is Sir Ravindra Jadeja doing a wonderful fielding job, analyzing how far the stumps are, at what angles the stumps are, and he hits the ball correctly. So within fraction of seconds, he is able to judge and hit the stumps. The same goes with the monoplanar technique. It's all about how you judge and how you orient. So with this, we can go ahead that as Dr. Harmi has already pointed out, that in bullseye technique, if you see that there is a torque which has been mentioned in one of the papers. So I will just go in details about the same thing. In the bullseye technique, it has shown that when you enter from the bullseye puncture, it is you enter from point A to point C. So once you dilate from A to C, when you enter the kidney, the maneuvering of your nephroscope can have a torque, and it becomes difficult, and it can lead to bleeding also. But when you're doing a monoplanar puncture, you directly come from point B to point C, and it is in the straight line, and you can easily maneuver your nephroscope inside the kidney. So I will close my talk with saying that practice and love for PCNL will lead to you a perfect puncture. Be the Arjuna of the game. If he can, we can. Thank you very much.
So that was excellent rebuttal from both Dr. Harmi and Dr. Harsha. We'll have expert comment. A couple of questions which viewers have asked live. Dr. Harsha, does whether monoplanar actually causes less blood loss, do you mean to say, as compared to a biplanar technique?
No, I won't say less blood loss. Every puncture has its own blood loss. It is all dependent upon how accurately you are hitting the calyx. Monoplanar don't cause more blood loss than the biplanar or the triangulation technique. It can be compared. It is not like that it causes less and the other techniques are causing more blood loss. But if you're doing it rightly, every PCNL has the risk of bleeding, and that goes same with the monoplanar.
Organ damage in monoplanar versus biplanar, any adjacent organ damage, is it the same or is there any difference?
Actually, I searched for the papers, but I was not able to find one. But with our own experience of almost 3,000 PCNLs, I have not encountered any bowel injury or any internal organ injury while doing a monoplanar technique. The reason for this, I have already told that we try to come more vertically and more medially in a monoplanar technique. So this bypasses the bowel region and other internal organ regions. When we are doing a monoplanar technique, we are very close to the kidney, and we have to only traverse 2 to 2.5 centimeter distance to reach the desired calyx.
That was excellent, and we'll hear the expert comment. Sabnis sir, what do you think about the two technique? What are your views?
These are not two different techniques as such, but I feel it is just an experience which makes you to have the second plane. I think Harmi rightly pointed out, and I entirely agree with him, that once you keep on doing it, and once you puncture it in the 0 degree, almost 70-80% of the times you know that you are in the system or not. However, in 1 or 2 attempts, if you don't think that you are in the system, no harm in just turning the C-arm, rotating it to 30 degree and see whether you want to be superficial or deep. So I think it is just a matter of experience, whether it is monoplanar or biplanar. So I just want to comment on the Harsha's thing, that one should not be adamant that I will do only monoplanar. You can do monoplanar, definitely, no doubt. But if there is any doubt, or if there is any, if you are not able to hit it, no harm in rotating the Siam. He has shown the picture of Ravindra Jadeja hitting the stump, but at the same time, he has not shown the missed throw, which he has done several times. So it is not once in a while, yes, perfect, it is all right. You are absolutely on the hot spot. He is on the hot spot. So you can be on the hot spot, but at the same time, you can't be on the hot spot all the time. You have to see the cold spots also. So I think it is just the extension and it is one of the same thing. So that is what my comment is.
Madhu sir, what are your views?
See, I think it's no different from what Dr. Sabnis said. If you recall, it all started on a flat panel fluoroscopy table when Dr. S.S. Bapat did his first PCNL. It was on a fluoroscopy table, monoplanar. But then he used to use ropes to turn the patient to get the 30-degree view. So you need the second plane if your first puncture fails to enter the pelvic axial system, and that's a reality. We all know that. And this is also true that with experience, and I think Harmi pointed it out very correctly, you may not require the second plane in a significant percentage of cases. So I think there is no debate on this.
Paul sir, your comments?
The group, I'm really passionate about this particular subject. And I feel Harsha and Harmi, with all due regards to you, you have seemed to miss the bus. Harsha, I feel, believes that monoplanar is just put the Siam in 0 degree and go straight. Even when you turn it 30 degree and keep it in the same throughout, it is again a monoplanar. The main difference between monoplanar and biplanar is, listen to me, whether you want to see with one eye only everything and you want to see everything with 2 eyes. There is a lot of difference between accuracy. If you ask Jadeja to take a catch which has to be absolutely correct with one eye closed, whatever experience he has, he will miss it. He is likely to miss it. It is one eye will show you only one plane of length and breadth. When Harsha started the video and on the screen he put the needle at 0 degree and the Siam at 0 degree in monoplanar, when he put the needle tip on the skin under fluoroscopy, it was shown in the calyx. The needle tip was on the skin, not in the calyx, but in image it was seen in the calyx. Then he went on going in deep. If you continue to maintain in 0 degree only, or only in one plane, maybe 30 degree only, and continue to go deep, as Harmi said, the last 1 centimeter is most important. You will not realize whether you are superficial or you have gone through and gone away, forward, much further. Therefore, to see accurately, because puncture is the main thing, and this has to be very perfect. It is not the competence, it is not the results, it is the accuracy. If you need the accuracy, you have to see the second view, whether you are really superficial or you have gone further down, which will be shown only when you open the second eye. Monoplanar is only one eye, biplanar is with both the eyes. Try to drive a car today only with one eye. Why to drive a car? You just eat your lunch today with one eye closed. You will miss it. You will not be accurate in taking the grass, taking this spoon. So it is such a different thing. Definitely when you mature, when you get experienced, even in one plane with your mind, as you have said, you come to know you are going through the skin, fat, muscles, then you have reached to the capsule and now suddenly give way and you are in. But not everybody in the beginning will realize it. He will need a second plane to see whether he is really reached inside or he is not reached inside. So that is the gist of the matter. Biplanar is a very good thing. You should, in the beginning, learn it. And once you are thorough, 90% of the times you will be successful in monoplanar only. You will not need the second plane. But beginner, at least 80% of the times he needs the guidance of the second plane. I think I have been able to make the topic clear to all of you. Sorry, I took a little long time.
So no, sir, it's the words of wisdom and nicely explained, and we take it positively. Yes, definitely what you said was absolutely right, sir.
Thank you,
So
sir.
we move on with the next topic. I would like, yes, sir. Will like to invite Dr. Mishra, sir. Hello, am I audible?
Yeah, please go ahead.
Yes, you're
I'm having
audible.
some
Please go ahead.
Yes, sir. I would like to invite
Yes,
Dr.
yes,
Dilip
please.
Kumar Mishra, sir, who we all know, yeah, who is a superstar in PCNL, in the prone PCNLs, and the both, and Dr. Aditya Sharma, who is the king of supine PCNLs of India. So we like to have a debate on prone versus supine PCNL, and I would like to invite first to talk Dr. Dilip Kumar Mishra, sir. Kindly go ahead, sir.
Thank you, Harsha. And I would like to thank Starbucks and Alto for giving me this opportunity to participate in this debate. And are my slides visible?
Yes, sir. Yes, sir.
And
Go ahead,
I'm
please.
audible. Okay, fine. So first of all, before and only, I would like to greet all my three legendary experts who are sitting and who have been my teachers all throughout, Dr. Madhusudan Agarwal sir, Sabnis sir, and S.K. Pal sir. And it is nice to have this debate in front of all the three of you. And the topic for the debate is PCNL, whether it is to be done in prone position or in supine position. Now here I have listed supine as question mark ABC XYZ hashtag because my dear friend Aditya, who is my favorite opponent, I would say, because we have had this debate before also, and he would describe all sorts of positions except for supine position. So I would start my presentation, and this is the flow of winners. I would say flow of winners because each and every point I would explain, and I would tell how it is important with respect to prone versus supine position. So why we call it supine when it's not? Now this here we see this is postural position which is described by Aditya in his paper, and I do not see in any way it mimicking or it is resembling supine position. It is totally lateral, and here and there stirrups are applied, and I don't know what position it is. Another position is GSME position. So PCNL is done in supine, so-called supine position, which are these positions, not in exact supine position, which is this position. I don't know how anybody could do a PCNL in this supine position. Coming on to prone position, so prone is prone. It is not some fancy name. It is just you put the position in the prone position, that's it. And it is easy to position. There is no extra stirrups or supervision required for positioning the patient. You can have a cup of tea while the patient is being changed to prone position. There is wide area available for puncture, and you can do a bilateral PCNL also if required. Now coming into the anatomical position of the kidneys, we all know this is a prone diagram, and here you can see the spine is lying posteriorly and kidneys are lying just lateral to the spine, and kidneys are placed posteriorly interpretatory. They are just akin to the spine, and the anatomical axis of the kidneys, you see it is pointing 30 degrees above the coronal plane in the prone position. So it is a normal anatomical axis of the kidneys in this position. I discussed that since supine position is in so much in vogue, so I thought maybe spine surgery also could be done in supine position. So I asked one of my neurosurgeon friends. He said, "Are you gone mad? How can you do spine surgery in supine position?" So coming on to the science of puncture in prone position, when you see RGP in prone position, we can see the posterior calyx, which is nicely defined. Posterior and calyx are defined. We have a proper scientific reproducible techniques, which are at least 7 techniques to puncture in prone position. It's not a hit and trial in prone position. You can do bullseye, as you already seen, monoplanar, biplanar, also many techniques are there. Triangulation technique is there. Then when we do a puncture in prone position, we have the shortest and direct path to the calyx. It is the shortest path which is going through the skin. And it is important because if you want to maneuver your ampla sheath into inside the pelvic system, if you have a small tract to the skin, then only it will be easy to maneuver, otherwise it becomes very difficult. Now, it's also easier to go through a supracalyceal axis in the prone position because it is just lying, just beneath the skin, the supracalyx will come. Now, when you do a supine supracalyceal axis in supine position, the tract is longer and you might have to do a considerable, take a considerable longer distance to reach the supracalyx. Now, signs of puncture in prone position. Here you see, only this red lined area is available for doing a puncture in supine position. And the kidney is very mobile. It makes the puncture very difficult. You may need to give counter push to stabilize the kidney for making a puncture in supine position, and there may be chance of torsion on the pedicle. Now, this paper, which has been described by Hopper et al. In 1987, has been widely publicized by Dr. Guido Gisti, and saying that in supine position, retrorenal colon is 1.9% versus 10%. Now, I would say that this is an old discordant study, very old study. It compared 500 supine CTs versus 90 prone CTs. And when we reevaluated the data, we found that frequency in prone patients is just 4.7%. And it is exclusively at the level of lower renal poles in 60 years of age, older adults. And it is when the colon is extensively distended with gas. Now, we all know that when we do invasive renal procedure in prone patients, we approach it 30-degree posterior lateral. So we avoid colon in almost all the cases. Now, similar paper was again put up by the same authors 2 years before this paper, and they have considered all retrorenal colon cases, which is even if the colon is lying lateral to the kidney, then also it is considered retrorenal colon. And they quoted that it is just 1% of the patients. So it's just fast. Now, coming on to the next technique, which when we did a puncture, then we need to do tract dilatation. So when we do dilatation in prone position, the movements are more precise and controlled in prone position. Whereas in supine position, they are passive movements and they are not that well controlled. The tract may be longer and it may lead to kink in the gynware and loss of the tract. Coming on to the pelvic system room and scope movement. So scope movement is very difficult onwards because of the table edge, which is just nearby in a prone supine position. It is collapsed also, and it may be difficult for beginners to access the pelvic system in a supine position. In prone position, it has never posed a difficulty for stone extraction. Coming on to the anesthesia issues. Now, Aditya will definitely say there are no anesthesia issues in supine PCNL and all. But in India, at most of the centers, we do PCNL in spinal anesthesia. So it's not a worrisome thing. And even if we want to do it under GA, so we put the patient under GA before positioning in prone. So there is no issue of airway, secure airway in prone position as well. This is a paper, Chinese paper, published in 2015. And they have shown that regional anesthesia may prove a better alternative to general anesthesia. Now we have a raging pandemic going on and ventilation issues. Even the Ministry of Health and Family Welfare says that proning is better for ventilation in cases with COVID. And this is again a COVID patient undergoing ventilation in prone position. So what are the real advantages of supine position? Yes, I agree. We can do ECIRS in this position but it is required only a select few cases in which there are multiple stones in different calyces, and it will help to reduce secondary punctures. Now again, we have got one equipment. This is a paper published by us again. It's a novel flexible mini nephroscope for using in mini PCNL. And instead of doing ECRS, we can use this technique for going ahead with doing a nephroscopy with the flexible nephroscope. So we can do better. We need not assault the ureter also in this case scenario. Now coming into the data, this is an CROAS study published, and it has shown And operative time is more in supine PCNL. Lower power punctures are more in lower supine PCNL, and there are more failed access and perforation in supine PCNL. Again, coming on to this paper, which is published in BJUI, they have compared prone position with all the possible supine positions. And here you can see ease of puncture is more difficult in supine positions. Ease of tract dilatation is more difficult in supine positions. Multiple punctures are more difficult in supine positions. And combined RIS, though sounds easy, but it may be sometimes unfamiliar because of the curved torso and all those things. So with this is again a paper which is concluded and saying that we got multiple advantages of prone position. And with this, I would conclude because I think I'm exceeding time. So thank you very much for listening. Over to you, Aditya.
Thank you, Dilip. Thank you so much.
Excellent presentation, Dilip sir.
Should I go ahead?
Yes, Aditya sir, please go ahead.
Okay. So I can very well feel the hiccups and palpitations which Dilip is having, because obviously when you don't have much facts, then you know. Anyways, thank you, Dilip, for being so soft. But my apologies in the beginning only because I'm not going to be so soft on you, and definitely you are going to get hard time defending what you have just said. Okay, so there are two ways of, I guess slides are visible, I can go ahead. So there are two ways of winning a debate. First of all, you can, pull the other person down, or the other way is to draw a longer line. So I'm going to choose the later option. I don't go into details of how supine PCNL is done because that's not part of the debate, and why and how it is. And I appreciate Dilip has shared a lot of his personal, limitations in terms of doing a successful supine. But I can ensure that with better observation and training, he will master supine like he does the prone PCNL. And the last line in my introduction, in this debate, today I'm, in fact, in this year, 2021, I'm right at the middle where my prone PCNL numbers are equal to my supine PCNL numbers. So I can tell you honestly, in an unbiased way, what supine scores better than what prone cannot do. And honestly, there is no debate. If you are still in denial of the pandemic of supine PCNL, it will be a big problem. So supine has had its share of evolution. Yes, there are a variety of positions because supine is evolving. When something does not evolve, that is the where science stops. So to put the facts straight, my data versus your data, there's enough data to suggest that supine PCNL has equivalent stone clearance rate. It can be done in all sort of stones, all burden of stones, all location of stones. And yes, there can be absolute indications of supine like pelvic kidney, kyphoscoliosis. So there are various aspects. And when we say something is a winner, we have to see from the perspective of everyone. So that includes the surgeon, the anesthetist, the patient, and hospital. So does the supine technique give advantage to anesthetists? Yes, of course. I'll share more data, but this is the comparative ventilator and cardioperfusion profile in various positions. And we have compared and we have found, and it is the standard text from the textbook of Miller, which is a Campbell for anesthetists, which shows that supine position and the lateral position, which we do, has excellent ventilation and perfusion profile and cardiovascular profile. So spinal anesthesia, again, of course, as Dilip said, that spinal can be done in prone, of course can be done, but talk to your anesthetist how many times they are really comfortable. Can they do it in every patient? In my, at least 90% of supine PCNL are done in spinal anesthesia. There are definite advantages. There are patient-related complications. I'll not go too much into the details of those, which are well documented. Patient has not come for this acupressure therapy where the pressure, so many pressure points at every part of the body, which you really need to secure. You may get away by not securing them in many of the cases, but you can always have problems. In prone PCNL, all the fluid keeps on falling over the patient. This can cause hypothermia in certain number of patients, but being a warm temperate country, we can get away, in such hypothermia because anyways it's so hot anyways. Bleeding, again, there is data so to suggest that supine has lesser bleeding, lesser infection, lesser incidence of urinoma, lesser sepsis because of the lower intrapelvic pressures. Colonic injury, I think Dilip himself has made it clear there is clear advantage of supine position in terms of avoiding a colonic injury. I mean, it is like a in vitro study where you can say 10%, 2%, but still there is no evidence or paper which shows that supine has higher incidence of colonic injury. I would say it has anything but lower incidence of colonic injury because in lateral position, this colon almost falls away from the kidney, which we every time experience when we do laparoscopy for our kidney positions. And there are special cases, of course, obesity, COPD, the patients with neurological issues who can't be given GA, who can't be put in prone position. So there will always be situations where you will get stuck. What's the surgeon's point of view? You can sit and operate comfortably. You don't have to spend $2 million for that. And of course, except a very few seasoned PCNL demonstrators, I have not seen in a conference demonstration where people can avoid exposure of radiation to their hands while doing puncture. Every time hands are visible, they say, no, this time it is happening. But when I do at my home, I never expose my hands to radiation. The hands are never exposed to radiation in supine PCNL unless you want it to. And all the time, the surgeon is at least 2 to 3 feet away from the C-arm and the field of exposure. Spontaneous stone drainage is there. In my personal experience, I rarely use a forceps. So for the removal of fragments, is the procedure versatile? Yes, you can do all sorts of access. You can maneuver from superior to inferior calyx, inferior to superior calyx, far better than prone. Supine PCNL is more suited for stag-on stones because once you combine it with ECRS, you give better stone clearance and quicker stone clearance. So of course, this has clear advantage. Prone, again, people say theoretically they can do ECRS through prone position also, but practically how many actually do it? And same goes about the use of flexible nephroscope. There is a vast difference in terms of scope movement while you put scope from the PCNL track and when you put scope from the below. Your accessibility is far better when you put scope from the below. And yes, supine can salvage you from difficult situations without changing patient position too much. Stone migrates while doing URS in the upper ureter to the kidney. Just tilt the patient a little bit, do a supine PCNL. Or if the RIRS you get stuck, you're not reaching the inferior calyx, take a small puncture, do a puncture wash, and many times stone comes out. So these are the various ways. The versatility is far better for the procedure compared to prone. And again, mini PCNL adds to its versatility. How does the hospital gain? Yes, the quality of life of your staff is much better. Ask them while they help you shifting heaviest of the patients. For supine or the forcemal position, you need just one assistant apart from anesthetist and the surgeon to shift or you turn your heaviest of the patient. Of course, better OT turnaround time, spinal anesthesia, lesser complication, lesser transfusion. So ultimately, the overall cost of the procedure comes down. You don't need specialized padding. You don't need specialized mattresses. This is a Montreal mattress which cost hell lot of money to if you really have it. I don't know anyone have it in India. So overtime is saved at many stages. Anesthesia, positioning, single painting draping is done. Quicker drainage of stone, quicker patient turnover. So these are all the ways where the hospital and the entire people around involved in the treatment of the patient are gaining. In the bottom line, PCNL supine position is safe and effective. It is a must-have neurological skill. If you are still in the denial of the pandemic of supine PCNL, you are going to miss the bus very soon. So stop. I think that time has come when the people used to ignore supine like, oh no, it's nothing. Then they said, okay, this is some funny thing. I think Dilip is still stuck in that time. But now you are having the, by the fact that you are having this debate that supine is a strong contender, and by this fact, supine has already won. Thank you so much.
Very nicely presented, Dr. Aditya sir. Very innovative slides and presentation. So we'll start the rebuttal round. It's up to you, Dr. Dilip sir.
Thank you, Aditya. It was a very nice presentation. I thought the pandemic was of COVID or of supine PCNL. I don't know, because if the pandemic was of supine PCNL, I think everybody would be doing supine PCNL only, not prone. And as far as I can see, this group, whoever is present in this August gathering, all our experts or all other people, Harni from Dr. Harmi from Philippines, Dr. Harshawardhan, everybody was doing in prone position only. Whatever videos I saw, I didn't see anybody doing it in supine position. Now, I would just quote our three experts only who are sitting right here, Ravin Sabnis sir and Mahesh Desai sir from MPH Nadiyad, Madhu sir from Rainbow Hospital Agra, and Pal sir from Delhi. Now, I have asked personally all of them, and in MPH they do 800 PCNLs per year, and more than 95% they do prone position. In Rainbow Hospital, again, we do 600 PCNL per year, and it's more than 95% are prone position. And Pal sir, he does more than 400 PCNLs per year and more than 96% in prone position. And I asked him, when do you do supine PCNL, sir, Pal sir? He said, only in selective cases, suppose somebody is in ICU, and only in select few cases he will do supine PCNL. That also when the patient cannot be turned prone. That's what he said. So I don't think any pandemic of supine PCNL is going on, Aditya. I think you need to get your listing clear. Other thing which I noticed was that whenever somebody is done a supine PCNL, so supine PCNL is in vogue, like, it's a fashion. So whenever somebody is a supine PCNL, they would just put it on Facebook or put it on Twitter. I did a supine PCNL, just to, go gaga about it. And once they have done it, then they will go back and do prone PCNL because it's the bread and butter cases. Now, this was a webinar organized by Sabnis sir when the pandemic has started initially, and it was in 22nd April last year. And Dr. Guido Gusti, who is the master of supine PCNL, was there. So Dr. Sabnis asked him, Guido, how do you do supine PCNL when you get complex cases like this type of cases? So you hear what Dr. Guido Gusti had to say about it.
My message is that I'm lucky enough that in Italy I have easier cases than this first.
So he said, I don't get such type of cases at all in Italy. That's why I can do supine PCNL in all my cases. Now these are a few cases of staghorn stones which we do PCNL in our center, and I see means it's very easy. Very easily in one puncture or maybe more than two puncture you can clear all the stones. And any stone which can be removed in prone position without thinking twice. That's why I say hashtag supine exit. So Aditya, thank you for listening. And that's Aditya. I think he should not be sitting like this. So I would conclude my talk rebuttal here. Thank you very much.
Very interesting rebuttal, sir. Aditya sir, it's up to you. You can present yourself.
Aditya, you're muted. Aditya, you're muted. No, not audible.
Unmute yourself.
Yes,
unmute
now it's fine.
Oh, it's fine. Sorry. So thank you, Dilip, for really going soft on this. And I can, of course, tell about Dr. Guido's comment. Of course, he was in Italy, and that's how he did his supine PCNL. But I am in India, and I do all kind of stones, and my supine is not limited by the stone burden. That I can share for sure. And of course, is prone better? Yes, in a smaller universe, you can think so. And I can really see how you have warmed up to all three judges here by quoting their work. But with all due respect, just because something is done more commonly doesn't make it better. And when you can have so much more, why you limit your experience and work by limiting to one position or one type of surgery? You can do ECIRS with supine. You can be more versatile. You can do simultaneous bilateral surgeries, and it is applicable in very difficult scenarios. So prone, what's the problem with the prone proponents? They think they are trying to fix supine. And but I would like to say supine is not here to fix what prone PCNL is lacking. Supine is a technique in itself. It is formidable and it is well established. So don't worry about fixing supine PCNL problems. And what is the dilemma of the prone proponent? First of all, why change? You should change because science is evolution, and now the technology is improving and the patient expectations are increasing as well. But again, you're in denial. Of course, you would say that I do prone, that is why you do prone. No, this is not right. You would be able to appreciate within last 3 to 4 years at least 25% of Indian urologists are doing supine PCNL, if not, which was almost nil if you talk about 4 to 5 years back. So again, quoting data, my data versus your data, studies come and they are retracted because they had own motives in trying to without much experience. When somebody goes out and publishes about supine, so I can say to talk about supine, one has to do enough supine cases first. About the anesthesia, so this is a real survey done among the anesthetists of Mumbai group, and this is what this was asked to them: if given the choice of supine PCNL under GA and given the choice of supine PCNL under spinal anesthesia, how many will prefer supine? So supine wins by a large margin. So I can really see that you have some anesthetists who really appreciates you and goes the way you want. But you can see these three companies, Nokia, Kodak, BlackBerry, what is common about them? They could not see the wave of change. Those who fail to evolve are going to perish. I conclude my talk here, and I am thankful for everybody for giving this opportunity. Thank you, Dilip. Thanks a lot.
Yes. Excellent rebuttal rounds. Very interesting points quoted by both of the speakers. So I would like to take Dr. Madhu's point on supine and prone.
Well, very interesting debate and good talks from both the speakers. One interesting thing which has come out of this COVID pandemic is that we were always made to believe that prone position leads to ventilation difficulties, and that was one of the reasons why supine was considered a better thing in patients with respiratory difficulties. And now COVID tells us that ventilation is better in prone position. So that is quite an interesting revelation. I don't know how it will change things in medical science in future, but it's interesting anyhow. The second thing which interests me is that the proponents of supine come out as if there is a fight against prone. As most of us have repeatedly said, that each new technique has its merits, and one has to be familiar with and one has to learn all procedures because each one has its place. So I have never understood even Guido trying to push away prone, trying to suggest that supine is superior to prone in a standard case of kidney stone. That's something which I've never been able to understand. Now, we all do supine in selected cases, and we all understand that it's a good technique, and we all understand that every one of us should know how to do supine, and especially things like ECIRS. We are very happy doing supine. But I still fail to see why should you switch from prone to supine in a standard case where prone is so much simpler, straightforward, and easy to do. And I think that's probably the reason why the world over, vast majority continue to do prone and probably will continue to do. So I appreciate Aditya for doing what he's doing and promoting what he's promoting, because supine is a very good technique to learn, and all of us need to learn it. But I doubt if it needs to replace prone.
Thank you, Madhu sir. Dr. Sabnis sir, your take on supine versus prone.
Yes, certainly. I think both speakers have done a wonderful job. And I just would like to summarize that the left supine and prone is like a left hand drive and a right hand drive. I mean, there is nothing, one is good and one is bad. The one which you are, if you are used to do a right hand drive car, then obviously you will continue to do, and then if you suddenly are given left side, you will get confused. And therefore, people who are practicing, and if you are trained to do supine PCNL right from beginning, if your mindset, if your imagination, everything is developed from the supine point of view, I think there is no problem of doing supine PCNL. You will continue to do a very good job as equivalent to what we are doing in prone position. Well, I see that many supine PCNL urologists, they are from the younger generation, so-called the what you have shown, the Dilip Mishra showed, we are all old timers now because we have done PCNL for 25 years in prone position. So we don't want to change because nobody wants to change what you have mastered for 2 or 3 decades. But I see many supine PCNL experts, they are doing excellent job and they will do a good job. There is no problem at all. So I think supine and PCNL, barring few limitations in both positions, I think there is nothing much to choose. Whatever you become expert, you continue to do that, pursue with that, and I'm sure it will have. But at the same time, the last comment which I want to make is Aditya Sharma is trying to promote supine PCNL for quite a long time. Supine PCNL was described almost 2 decades back. All over the world, people are trying to promote supine PCNL, and still they are in the stage of promoting PCNL. They are not in the stage of widespread supine PCNL. So that is one thing which we have to understand and make our own judgment what is good and what is bad. Thank you.
Thank you, sir. Rightly summarized. We'll take closing remarks for this debate from Dr. Pal, sir, about his take on supine versus prone.
My take is very simple. It is the patient which needs of the patient which decide whether we should do a supine or a prone. If it is a very complex stone as shown, and we have to make multiple punctures from here and there, the best many entry points, the wide surface area from where we can make entry can be achieved only in prone PCNL. If the patient is sick, having COPD, comorbid conditions, cannot be turned prone, it has to be done in the supine position. Regarding all these stories like OT time and personal OT requirement, people in the OT staff, that are all stories. If you are doing 20 PCNLs in a month and you are having the same staff, my staff can turn any obese to obese patient in 2 minutes from supine to prone. And maybe if I ask them, the same people for the first time to put a supine position, they will be fighting amongst each other. They will be searching for a sandbag because all supine are not supine. They are tilted. Someone will put right leg like this, someone put left leg like this, someone will put 30 degrees, someone will put 30 degree. So it is how your staff gets used to it. It is not the time taken. 2 minutes is good enough for any thickest patient to be turned prone. So this is my take. And lastly, it is not the anesthetist who is going to face the patient or choose the position. You have to face the patient. You have to give him 100% clearance. Anesthetists are only asking for the easy job. They don't have to be very much lined up, means strained up. So they want, okay, in GA, just give the supine and go ahead. So it is the patient, the need of the patient, and your unsuitability of the patient which dictates which position you should put. Both are equally good. You should be competent for both. Thank you.
Well, we have settled the score for puncture technique, and position. Now let us come. Let us come. Let us know about what is the best energy to break a stone for sag-on stone. We have Dr. Rajesh. Someone audio.
Yeah, we are having some sound disturbance.
Abhay sir, I think from your.
Abhay sir, just
mute yourself.
Yes. It's clear now.
Now, friends, I would like to mention here that we are running very much behind time. We'll have to do something about this.
Yes, we'll hurry. We have got two speakers, Dr. Rajesh Kukreja, who will be speaking to us about pneumatic lithoclast for stag-on stone. Over to you, Dr. Rajesh.
Thank you, Nitesh. Thank you. Host disabled attendee screen sharing. Can I have my screen sharing on, please? I'm getting host disabled attendee screen sharing. Am I audible?
I'll do it. I'll do it.
Still unable to. Still showing host disabled attendee.
I'm doing. Just give me a second.
Yeah. Sure. Take your time.
Aditya, you are the host. Can you do it? Aditya? Aditya?
Yeah, boss. Just a second.
I have not done it, Rajesh. Huh?
Abhay, you already started making unusual noises.
No, I have not done it. So you don't look.
Rajesh sir, please try once now.
Yeah, got it. Thank you, Nitesh. Thank you, Aditya. Yeah, so is my slide visible?
Yes, sir.
Sure. Thank you, Group Alto, and thank you, Starper Group, for giving this opportunity. And as I see, we have a very good attendance, more than 120 or 150 people already doing the live interesting debates. And thank you for the opportunity. So I straight away begin. Abhay, stop making unnecessary noises and don't disturb everybody. So now, when we come to the idle technology, holmium is very close to my heart. So actually, it's very difficult for me to beat holmium because it's very close to my heart. So now we are choosing the better amongst the best. Now, when we choose which one do I want here, because both are very good, we need to target the stone clearance, the time taken to achieve success, mobility, efficiency, and cost effectiveness. Pneumatic, we all know there's no heat generated during the procedure, thermal damage is not incurred, and it has a very low risk or a negligible risk of perforating the mucosa when compared to other lithotripters. Migration of stone has been quoted as a disadvantage, but yes, in the ureter, of course, there. In the kidney, and that too in the stagon, where is it going to go where the entire kidney is already filled up with stones? So this is a CROW study now. This is not a single institute, not a multi-institute. It's a CROW study on PCNL success outcomes. And one of the important factor marking the success of PCNL is the use of pneumatic lithotripsy. And this is published just recently, around 7 years back. So now let us come to individual factors one by one. Stone fragmentation and removal time. That's the most important. So does the stone hardness size matter? Yes, it matters. How? As the stone becomes harder and the density goes to more than 1000 HU, the stone fragmentation and removal time was the best for pneumatic lithotripsy, whereas for softer stones, it's very good for ultrasonic lithotripsy. But very important statement is the overall complication rate, stone clearance, hospital state is immaterially not affected by any of the energy you are using. Now, what about the holmium laser? As the size increases, as the HU increases, the total leasing energy and the total leasing time increases. This is opposite to what happens with pneumatic energy. So now let us have some comparative studies. So this is now comparing the three different types of pneumatic itself. And you see stones as big as stagons, as big as 577 square millimeter, huge stagons. And how much is the time taken by the lithoclast to clear the stone? Hardly 30 minutes. Very effective. And now when you compare pneumatic with laser, so now this is a study from Nadiad. Why I'm quoting this? This was a mini perk for small stones up to 15 to 30 mm, everything. And the average stone was only 20 mm. So now laser was using a 550 micron fiber and pneumatic was using the Swiss lithoclast. And what do we see? Total operative time, fragmentation time, similar. Surgeon assessed Likert score, similar. Stone migration was there, yes, with the pneumatic, and using the basket was more with the pneumatic, but all the success was similar. And this was for small stones with mini perk. Then you come to bigger stones. Now you have 25 renal pelvic calculi. What happens? The time taken by holmium laser now becomes more. So the smaller the stone, holmium is very good. But as the size goes up, the average operative time increases in holmium laser, whereas pneumatic is quicker. Does any of the energy usage have an impact on the renal function? So this is a very interesting study. It was published in the Indian Journal of Surgery. It obviously looks like a Chinese study, and what they've compared is pneumatic and holmium laser for partial stagons. And there's no difference between the operative time. But if you see the last statement, they have done sequential diuretic scans to assess the loss of GFR. And what they have shown, some infrequent severe renal function damage can occur. 2 units occurred in their study in laser lithotripsy. Why? Probable hypothesis due to prolonged high intrarenal pressure and mucosal thermal injuries. So this needs to be kept in mind when you're using laser for a long time inside the kidney. So comparing the mechanism and efficiency now, the next factor, Ashish Patil, he has to be there in the front when we are doing experimental studies. So a parabolic lithotripter at 2, 3, and 4 bar is absolutely comparable to a 6, 10, 15 watt laser. Now, these are low energies for both. You can upgrade the energies to both the devices. What showed importantly is that the lithotripter or the pneumatic bar would break the phantom, whereas a laser would always just make bore holes in the phantom. So, and the stone propulsion was equal. So again, the pneumatic energy scores over the laser. So let's see practically. This is how we have, this is our own Indian lithoclast. I'm telling you, this is the, which I am using, the Nidhi lithoclast. You have a parabolic probe, stably provided by a suction cannula for effective and fast fragmentation. There you can withdraw the probe for simultaneous breaking and suction. So you can set it as per you. And then once you're through, you can use it as a very effective suction cannula. That is a 3 mm 9 French suction cannula. You can use it to suck out all the dust. And then if you go for the imported technology, that is a triology where you have a pneumatic and suction, but now this is getting combined with the ultrasonic. So what do I think? Pneumatic and holmium are both excellent energies. Holmium laser has the advantage of producing smaller fragments. It's good for small stones where you're using mini perk. So the choice of intracorporeal energy would actually depend on the track size. The track size depends on the size and the configuration of the stone. So mini perk, where do we use it? Stones less than 3 centimeters. Standard PCNL, 3 centimeters, stones larger than 3 centimeters, and stagon calculi. So holmium would be my energy of choice for miniaturized PCNL, where we need smaller fragments and it's a low volume stone. Pneumatic energy would be preferable for standard track PCNL, where we need large fragments that can be retried faster to the large tracks. So why do I think pneumatic is a better energy for stagon? Efficiency, we have already seen fragmentation with suction, pneumatic scores over the laser. Time taken, we can see the larger the stone, the harder the stone, pneumatic scores over the laser. Stone free rates, both are equal. Complication doesn't make a difference. Cost effective, no two thinkings about it. It's definitely pneumatic which scores there. Thank you.
That was excellent talk, Dr. Rajesh. Dr. Abhi
was already making noise. I need to mute myself.
Abhay sir, there is a disturbance, sound disturbance from your side. Now it's clear.
Is it okay now?
Yeah, very clear.
Yeah, but okay. You are able to see my slides?
Please go ahead.
Okay, fine. Thank you, Ulto, Starperk, and respected moderators, Dr. Sabnis sir, Dr. Madhu Agarwal sir, and Dr. Pal sir. So I am here to defend use of lasers in stagon stones, and If you see all the references and all the quotations which quotes which were given by Rajesh, where most of them were for the mini perk and the use of laser for the mini perk, and he didn't touch upon the use of lasers in stagon stones. So we are here, Rajesh, speaking the use of lasers or pneumatic only in stagon stones. So what are the problems when treating the stagon stones? There are three major problems we all face. That is urosepsis, bleeding and residual stones. And if you see, lithotripsy does affect these two factors, that the bleeding and the residual stones and complications of it. There are various types of stone lithotripters which are available. Initially, we used to have hydraulic, electrohydraulic, then shifted to pneumatic, where we have used pneumatic extensively by most of the urologists. Then came ultrasonic, then came some combinations of dual ultrasonic and trilogy technology, and lasers have come which are now used for stagon stones. What are the factors which are to be considered during stone lithotripsy? Stone composition, what type of probe you are using to fragment the stone, whether the probe can be used with endoscopes, what is the accessibility of calyx with a particular lithotripsy machine, and what are the complications. Now, if you see the use of lasers in all this, stone composition, definitely the laser can fragment any type of stone, whatever the hardness it is. It is a flexible fiber, so very easy to use with all types of endoscopes. It can access all the calyces. The maneuverability with the flexible laser fiber with any endoscope is very, very easy and very, very convenient. And definitely there are complications. Rajesh has showed the references, but he didn't mention a single complication of pneumatic or the advantages of laser. And I'm going to show you the specific references of lasers to be used in stagon stones during PCNL. This is one of the references where they compared holmium laser with ultrasonic lithotripsy, but this was the initial study which they performed. And if you see, just let us look at the effectivity of laser in stagon stones. Though the operative time is more, the hemoglobin deficit is less with the use of lasers in stagon stones. And they concluded that the hemoglobin deficit is definitely less with use of holmium, but slightly longer operative time, and they concluded that it is a viable option and a safe and effective disintegration of stone does occur with the use of laser in stagon stones. When you directly compare the holmium YAG laser and pneumatic lithotripter in PCNLs, the complications of use of pneumatic group was definitely higher as compared to the laser group in terms of fever, bleeding and urinary leakage. The operative time was definitely longer with the laser. The cost is definitely high as compared to the pneumatic lithotripter, but if you individually see, the cost is not that much when you start using the laser, because the fiber lasts very long and both the modalities were safe and effective. Now, there was a comparative study of low power laser and high power laser in PCNLs for stagon stones, and they concluded that for stagon stones specifically, it is better to use a high power laser because the lithotripsy time significantly reduces when you use 70-watt laser as compared to a 30-watt laser. And because the lithotripsy efficacy, because of the vaporizing and the bursting of the stone is very, very rapid with the high power laser, and it is a safe option. Coming to the last study, again a very, very specific study of comparison between pneumatic lithotripsy and holmium laser lithotripsy in Guy's stone grade 4 kidney stone patient, that is stagon stones and stones with spina bifida or spinal abnormalities. Again, if you see the results, the drop in hemoglobin and the drop in hematocrit was significantly lower in laser group as compared to the lithotripsy group, and also the post-operative hospitalization stay was less with the laser group. The all other parameters were comparable, so they concluded that there was a decreased hemoglobin and hematocrit level with fewer hospitalization stay with the laser group, and it should be used for patients who have a risk of bleeding because of anemia, severe infection and hemorrhagic tendency. Now most of our patient has anemia and severe infection because of infected stagons, and laser is the best modality to be used because the chances of bleeding are significantly less. So let us summarize what we have. Parameters drop in hemoglobin and hematocrit, as we have seen in there are plenty of more studies, but I have chosen the more specific studies between the pneumatic and the laser. So definitely the drop in hemoglobin and hematocrit is more with pneumatic and less with laser. The bleeding is less with laser. Post-operative complications less with laser. Retropulsion. Now Rajesh said there is no question of retropulsion. Of course there is the role of retropulsion. When you fragment with pneumatic energy, the stone fragments, larger stone fragments, they go in multiple calyces, and it is very difficult, or you have to spend more time in retrieving all these calyces. You are able to remove all the stone fragments, but definitely the movement of the stone fragment after fragmenting with the pneumatic is definitely more, and the movement or retropulsion of the stone fragments with the laser is definitely less if you use a laser fiber. Hospital stay, again less with laser, more with pneumatic. Definitely the operative time is more because you cannot compare the energy mechanism or energy mechanics with the pneumatic and the laser, and the cost is more with laser. So more greens with laser and more reds with pneumatic. This is how we use, this is how we do our procedure. We always use a thulium fiber laser. We have latest started using it for stagon stones, and the main important technical point or practical point in this is you have to keep the energy high, between 2 to 4 joules. The frequency should be low, that is only 10 to 20 hertz, and use only in fragmentation mode. There is no need to use in dusting mode. So to have a good effect of the laser in stagon stones, we recommend two things. One, high energy, low frequency, high power laser, that is more than 30 or 40 watts. We use a 60 watt thulium fiber laser, and you can see the excellent fragmentation of the stone in the video. This is a 4 centimeter stagon with no bleeding, very clear vision and excellent fragmentation with thulium fiber laser. So laser is the preferred energy source because it is very effective. It is compatible with all the endoscopes. It has got less complications, and it is safe because of less penetration of less than 0.5 mm. Thank you. Sorry if my voice was cracking because there's some problem in my speaker, I think. I don't know.
Over to you, Dr. Rajesh, for rebuttal.
After what the Chinese have gifted the whole world for the last 1.5 years, you are still in awe of Chinese studies. I cannot imagine. The advantages you have quoted are of all miniaturization, less urine leak, less bleeding, less hospital stay. These are all of miniaturization. How does a laser and a pneumatic effect on this? So let's have an example. You said stone migration, laser will not let me. Let's see this. Now this is a stagon, classical case, complex case, and 2, it's like a bifid Y-shaped stone going into 2 calyces. So obviously what I did is I punctured both the calyces, and I punctured both the calyces, and I went in. So I went into the lower calyx tract, and I took out these all small secondary stones from here, and then through this I was able to manipulate into the upper medial calyx. And from there, now can the laser do this? No. I can know exactly where should I break the stone. With my lithoclast probe, I maneuvered the stone. I maneuvered the stone into the pelvis gradually. Don't try that ever with the laser fiber. It may just prove too costly for you. And with that, I maneuvered it into the pelvis, dragged it, and then broke into precise pieces. And with forceps, now you see this, how I can do it. I have maneuvered with the lithoclast probe, and then once it comes in my view, I have held the whole stone here and taken out in piece. So where there's no question of dusting, no question of fragments, small fragments migrating here and there. In fact, my lithoclast probe has helped me get the entire stone out of the system. Now, this is the advantage with this. I've shown you what you told me. There's more maneuverability. You can reach every calyx. You can, in fact, with your sturdy probe, maneuver the stone into the pelvis and take it out. And that you can't do it with the laser fiber. And single track clearance, I achieved for this, and no blood loss. Prone position time 45 minutes. And what else do you require from a Stagon stone? So why pneumatic for Stagon? Holmium laser is like the beautiful moon. Everybody loves it. It's beautiful, it's romantic, but it's limited to good dating for small time purposes. What about pneumatic energy? The rays of pneumatic energy are just like the rays of solar energy. Fast, super strong, harmless, and cost effective. Just what seems harmful may not be harmful, may be always harmless, like the manta ray. Thank you. Thank you.
Thank you, Dr. Rajesh. That was an excellent rebuttal to defend lithoclast. Over to you, Dr. Abhay, sir.
Okay. Rajesh, you said that the pneumatic is harmless. I don't agree with you. Are there any disadvantages of pneumatic lithotripsy? Definitely there are. There is physical damage of the mucosa due to fragmentation, and especially during when you fragment the impacted stones and hard stones. And also you must have seen perforation of the collecting system. We during PCNLs, when we try to push the hard stone against the renal pelvic mucosa, we have seen the stone going beyond the renal pelvis and creating perforations in the pelvic callaceous system. And also there can be bleeding because of the pneumatic lithotripsy during Stagon stones. Now this is a beautiful study where they have compared the tissue damage between ultrasonic, pneumatic and combination lithotripsy modalities, and what they have observed is very interesting. The chances of perforation with the renal pelvis are very high when you use a pneumatic lithotripter. When the force goes above 400 grams, there is a significant damage of chance of perforation, and when the duration goes above 3 seconds, between 3 to 180 seconds, the chances of perforation are very high. So this doesn't occur in laser, but this can easily happen with the pneumatic lithotripter. They also saw the cellular damage with the histopathology of all the three mucosas of bladder, renal pelvis and ureter. And if you see, there is a significant damage here till the muscularis propria with the use of pneumatic lithotripter with high energy and with the high force which is used with the pneumatic lithotripter. They concluded that the mode of lithotripsy, tissue type, probe force and probe tissue contact all significantly impact the extent of damage and the likelihood of perforation. So I would like to conclude, definitely laser is good because of there is no probe force, there is no probe tissue contact and there is no perforation. And audience, I would like to listen to this video where my opponent endorses my view of using the laser.
Why do you want to have a laser? Laser is an essential tool of a urology theatre. The discussion now is not pneumatic versus laser. The discussion we are now going forward is whether you're going to have a holmium or a thulium. So laser is extremely essential.
So I know Rajesh, you are saying this for the mini purpose. Definitely few years down the line you will repeat the same sentence for lasers in Stagon stones. Thank you.
Oh my God.
That's a good one.
So let us hear from our expert what they feel and how they choose their energy source. Over to you, Madhu sir. What do you feel? How do you choose your energy source for dealing with Stagon stone?
First of all, I must congratulate both speakers for making wonderful presentation and putting across the good things about both the energy sources so well. And both the energy sources are extremely versatile and useful in all kinds of stones, especially staghorns. So both of them have important place in management of staghorn stones. Most of us use pneumatic and nowadays even the combination, ultrasonic and pneumatic, the shock pulse, more and more for large volume staghorn stones. I think this is something which goes without saying, but we are increasingly using laser as well. And we are increasingly using mini perk for small and medium volume staghorns. So when you say laser for staghorn, you do not specify whether you are talking of standard PCNL, that is 24 or 26 French, or a mini PCNL. I would like to highlight that we are now doing more and more small staghorns with mini PCNL. So there is a place for both energy sources, and both have their benefits and limitations, which have been very nicely highlighted by both the speakers. Thank you.
Sabnis sir, what are your views?
I feel the small stones and the staghorn stone are completely different ballgame altogether. They should not be equated with each other. The objective of doing in a staghorn stone is completely different. Here, what is your primary objective is that you have to break this stone very, very fast. Otherwise, you will end up in multiple stages. And when you want to break this stone very fast, whatever laser energy source you take, it is going to be smaller than the pneumatic. And the other problem of the high power, which is supposed to break the stone very fast, even melt the stone, is that as you go with a high power, whether it is the holmium or the thulium, the vision becomes so poor that there is a snowstorm effect. The dust keeps on moving, and the moment you break for a half a minute, you have to wait for some time for that dust to settle down, vision to become clear, and that really prolongs the operation time and gets a lot of disturbance. And therefore, when we talk of a staghorn stone, I think the choice, if you are doing with the conventional PCNL or a slender PCNL, the balance is still in the favor of pneumatic. And what the Kukreja's video, which was shown, actually must be for mini PCNL, where I think the balance is completely tilted towards the laser. Laser is the preferred energy. But when we come to staghorn, the balance is still in favor of pneumatic. That is what I feel.
Paul sir, what are your views? Paul sir?
I guess
Paul, I think is
Pulsar is offline, I guess, sir.
I think you need to move on. You're running behind time.
Yes. So we move on with the next topic, where we come to the dilatation techniques. Like to invite Dr. Yogesh Kaze, who is a consultant urologist at Sahyadri Hospital and a good friend of mine. Dr. Yogesh, over to you for single-step dilatations in PCNL.
Yeah, very good afternoon to all of you. Thank you, Alto Group and Starpuck Group for giving me this wonderful opportunity. Myself, Dr. Yogesh Kaze, I am consultant urologist at Sahyadri Hospital, Pune. And my today's topic is single-step dilatation during PCNL, which I strongly believe and I've been practicing since long time. Am I audible?
Yes, you are audible. Please go ahead.
Yeah. So when the opportunity was given to me to present my talk, I was like, just like this seen in this picture, Indira Nagar ka Gunda. Soon I came to know that I'll be talking against Dr. Chandramohan sir. So few anger issues came up during this period. But like I already said, I strongly believe and I've been practicing single step dilatation in almost all of my cases. So that makes my job very much easier. I almost told Harsha, bhai, bachche ki jaan lega kya? Itna bada opponent de diya. Okay, so theek hai, let me try my best out and defending single step dilatation during PCNL. So we all know PCNL is commonly performed by all of us. The key step in PCNLs is puncture of the ideal puncture of the kidney and meticulous tract dilatation. So what is the ideal method for tract dilatation? The one which involves short time, the one which is affordable, and the one which is with no complication. So these are the common methods of tract dilatation: it's balloon dilators, the Alkane's telescopic metallic dilators, and the Amplage sheath, Amplage facial dilators. So what is single step dilatation? Single step dilatation is dilatation of the kidney during PCNL with a pre-fixed sheath size. I mean, you fix out that whether you are using 20 French sheath, 24 French sheath, or 30 French sheath, and you do it in a single step over the Alkane's rod usually. So that is single step dilatation. So Dr. Travis from Australia in 1991, he carried out the canine experiment with 24 French sheath dilatation in a single step and found out to be safe and effective. While Dr. Antonio Fratini from Italy was the first one who published single step dilatation. He did dilatation ranging from 25 French to 30 French in a single step. And since then, single step dilatation is fairly practiced worldwide. So few things have to be answered: whether the single step dilatation is safe, whether it is effective, what are the advantages, and what are the concerns. So what is the scientific data is saying regarding single step dilatation? I'll share my references at the end of my slide. So one thing is for sure, that single step dilatation reduces the operative duration. It reduces the radiation exposure to the patient as well as to the operating surgeon and the OR staff. The complication rates such as overdilatation, underdilatation, perforation of the PC system, bleeding, and the stone-free rates are almost comparable between telescopic Alkane's metallic dilatation and the single-step Amplage dilatation. So what do my पारखी नजर like? मेरी पारखी नजर क्या कहती है कि अगर वही रिजल्ट आपको कम टाइम में मिल रहा है तो कोई वो क्यों करे, सिंगल स्टेप डायलिटेशन क्यों ना करे? I must admit that I have a similarity with sharing with the Salman Khan. Like we have been prone for prone position over the years. Lot of webinars and talks about supine PCNL haven't motivated me to yet to start doing supine PCNL. So I am a pure prone guy, and limitation of my talk would be I don't know whether the supine PCNL and single step dilatation during supine PCNL is equally good enough, but I have asked Dr. Aditya, who is practicing supine PCNL. He says that he does single step dilatation during supine PCNL also. And I've seen Dr. Chandramohan doing sequential dilatation during supine PCNL. So, and I couldn't find many studies about supine PCNL and single step dilatation. There is another concern that if there is a previous surgery scar, especially the open pyelolithotomy cases, is single step dilatation safe in these cases? So there are numerous studies which support the single step dilatation during in a patient who has undergone previous surgery, like open pyelolithotomy, big scar. Scar tissue makes the dilatation bit difficult, but in an experienced hand, single step dilatation is effective. And what about pediatric cases? Again, a lot of references I could gather from my search that single step dilatation technique in pediatric population during PCNL is effective alternative to stepwise dilatation. These are all the references I could gather from the my search. So I hope that there is a good saying that a journey of 1,000 miles begin with a single step. So I hope that my talk would inspire many of us doing single step dilatation during their journey of 1,000 PCNL. Thank you so much.
Excellent presentation, Dr. Yogesh. The next speaker needs no introduction, as we all know that we call him as the super man of urology and the Facebook star, Dr. Chandramohan sir, I invite you for your talk on sequential dilators in PCNL.
Respected panelists, the Alto team and StarPec team, thank you for giving the opportunity. I will share my screen without wasting time. Yogesh, to be honest, there is a lot of literature available for sequential and single step dilatation. Actually, you are mentioning Journal of Surgery and Medicine. Come on, yeah. Journal of Surgery and Medicine, why should you take 2019? I might have given articles, many Journal of Endourology for single step dilatation. Okay. Smaller the dilatation, lesser the sequence, bigger the dilatation, sequential dilatation is required. It's not the question of defending. You have same patient on the right side hydronephrotic kidney, on the left side long infundibulae. When this long infundibulae is there, even if you are very precise onto the cup of calyx, after that your travel should be slow and steady. Slow and steady. There are various three-dimensional anatomy will be there to understand the pelvic calyceal system. Even though you see at 0 and 30, that is not enough. Majority of the times dilatation, you don't see 0, 30. You see only 1. 1 means it may be wrong. There may be a small curvature of the anterior, posterior, lateral, medial infundibulum. You miss, you may hit it. So tract dilatation is very important. Lumbodorsal fascia is the most important thing. In children, you can't imagine the amount of elasticity. Anybody who is doing lap, anybody who is doing PCNL will understand how difficult the elastic tough structure. Imagine in a six-pack person doing single step dilatation, very difficult. These are the dilators very commonly used. You know, in the Western world, balloon dilatation is a single step dilatation. Entire literature is comparing balloon dilatation. In India, very, very less. I don't know why. But as far as the serial dilatation concerned, only 2. The Amplage dilator, which everybody uses, Alkan dilators. I have seen all the 3 panelists here. Majority of the times in the conferences showing, reason I am showing in this, when you do puncture, there is a chance that 1 or 2% of the angle deviation, the guide wire we go in, after the guide wire goes in, when you take out the needle, it will not be 100% straight line. You should aim 100% straight line. Even the skin, see, this is one sent by Harsha to me, your close friend, which is a nice one. Everybody does with this first. Why? You have to perforate the rectus sheath. You have to perforate small amount of the kidney parenchyma before you put a bigger one. I am doing a little 2 more, 3 more times. You do first up to 6 and 8 French. After that you go to 20 and say that single step dilatation. Where is the single step dilatation? No, that is not the single step dilatation. You puncture and go with 30 and then do it and then see how much pressure it will come. Advantage of sequential dilatation is you can eat many times, you can reuse. I don't know how many times we have used Alkan dilators. Cost is very less. Obesity, long tract will be there. Sometimes you move the needle and get into the puncture. That type of dilatation, if you miss, it will go wrongly into a wrong tract and that guide wire can never be used. And by chance, if you have leaked the contrast, it makes hell. Hypermobile kidney, you see here, I am not doing this case. My colleague is doing, and see amount of the movement. You will go to the opposite kidney and do the opposite side PCNL with this type of movements, especially in supine PCNL. I do agree prone PCNL is done well, but any PCNL, the kidney moves and that may damage, especially in children. See this initially only guide wire is giving this much trouble. It happens when your tract is long, when you are oblique, then unless you, even sometimes we put back of the Alkan rod, make a perforation in the rectus sheath and then go. Now coming to the staghorn, you will not have any space, you have to go up to it. What we all do it, we put a rod, the rod will feel the stone anterior and posterior, you can place it, you nug it and then slowly, even the guide wire is not there, don't worry. First guide wire up to the Alkan rod is important, whereas it is not like that. If you are doing very rapid force with a large one, guide wire slips off and where will you go? Whereas if you pass one Alkan rod, you are saying that Alkan rod I will put. Why you are putting Alkan rod if you are doing single step? No need. Directly you go with rod, nobody will go. You have to make some give way in the rectus sheath. See, this is the on the edge of the stone. You are there with the ampla sheath, and you are breaking it. Now, all roads are not like these smooth roads. They will be tough roads, post-operative cases. The literature has shown 2020 article. Why are you quoting the article of Journal of Surgery and Medicine here? I have not heard of Journal of Surgery and Medicine. It is looking like 1920 article. You have so many articles you might have shown. See, the rigid metal dilators are very helpful in dense fibrosis. Even one time if the PCNL is done, entire tissue becomes in that area very tough. You see the CT, it will be adherent. And if you suddenly listen the sound, disaster, you can perforate anything, and if it is anterior towards the renal hilum, oh, that much disaster you don't want to take. Sometimes even the alkane perforates, but those perforations are submucosal, you can get away. So here you see in children how the small child, when you are doing supine PCNL, back of the rod I am using, I will go to the dilatation, they see the alkane rod, this is the puncture. After that, would you like to go directly with 15 French or like that? No, you pass back of the you see here nicely, these are like a plastic surgery. You have to respect what our Ramakrishna says is that the infundibular mucosa should not know that you are entering into the kidney. That much slow and steadily if you do, every day you will get away. Just because you are doing it now, every day you should be safe. Do it meticulously. See, I am rotating slowly. Next dilator is kept. This is a small kidney. See, after that this is single step dilatation only. But you have used back of the rod, you have used the front of the rod, then you have used the inner optator, then ultimately this is 12 French only. But you have done it in 3 sets. Then baby kidney will be very good. Now you see here the paper. This is an old paper. I don't mind. 2001 they said that it is dangerous. Kidney can avulse. This is the only paper I am showing, old paper. 2012 alkane dilator first choice in secondary or tertiary cases. Presence of mobile kidney when the guide wire cannot be this thing. Large study, equal comparable complications in both the cases. See, group B is balloon dilatation, and most of the complications are with balloon dilatation, which we may not be doing. High volume centers, hemorrhage is lesser. I have seen many of the Indians using alkane dilatation. Wonderful invention in fact. Operative time is same. I take 1.5 minutes. As SK Paul sir said, 1.5 minutes versus what even alkane dilatation when you are doing, when knob is there, you have to just go without using. Every time you don't use CM. Why will you use? You have dilated, go slowly, knob will end. After that short you do, and then see whether it is there or not. Successful dilatation, sequential dilatation has high successful dilatation rate than other things. So renal function loss, this is a paper which is from the Journal of Endourology 2011, that renal parenchymal damage is more in DMSA if you do direct dilatation. This is one of the same study where no scar, small scar, moderate scar, large scar. The small scar is present in post-operative cases of balloon dilatation. This is the largest study of 5,537 patients, Crowe study, where they said high volume centers. You also wanted to do more number of cases. I think you are doing. Then why to do when literature has shown that? See, in all Asian countries, you are doing only the sequential dilatation. Only in Western countries where stones are only 1 centimeter, half centimeter, I will not do PCNL at all. I will do RIRS. Then where is the role of the direct dilatation? Like that, Crowe study itself has said that operative time has no difference much, perforation has no difference much, bleeding has no difference. So slow and steady wins the race. Over to you.
Yes, Yogesh, please start with the rebuttal slides.
Yeah. So,
I stop sharing. Sorry.
Yeah. Okay.
Sorry.
So let me tell you why I quoted old studies is because I wanted to make everybody believe that the single step dilatation is nothing a new concept. It's been practiced since years, and it's been proven safe and equally effective as telescopic dilatation. My talk was regarding single step dilatation using alkanes facial sheath, not the balloon dilatation as you as we would have thought, sir. So let's start the rebuttal. Single step dilatation versus telescopic dilatation. Everything I do is backed with the solid research. Let's do Seedhi Baat, no bakwas. Single step dilatation is safe for the patient. It is equally effective as that of a metal telescopic dilatation, and it is fast. You save a lot of time than the telescopic dilatation. If you save a lot of time, what kids like me do, we make team on Dream 11. We pay our credit card bill using cred and earn reward points. Adult will do more cases of PCNL by that save time. And legends like you, sir, will do workout. That's what the legends do. So saving time in each and every case is important, sir. I want to stress that the single step dilatation using Ampla sheet is easy. You don't have to learn or master any different technique. It is, I feel it is better in supine position also because the kidney is lot more mobile owing to the more compliant nature of the anterior abdominal wall. So there would be less chances of wire kinking and wire coming out. It is safe in pediatric cases also. It is safe in patients with scar. Harshawardhan, mute yourself. And obviously, single step dilatation is with less radiation to the patient, to the operating surgeon. So please remember, single step can do even the toughest job. Like the Bahubali was a tough warrior to kill, but Katappa did it with the single step. So single step dilatation, everybody should do. Thank you.
Yes,
I share my screen.
Chandra sir, please go ahead.
Yes, I am sharing my screen. भाई योगेश तुमको समझ में नहीं आया, मैं 2 स्लाइड्स में समझाता हूँ, समझो. ये है हमारा रिबटल है. इफ अदर वे अराउंड डायलेटेड सिस्टम वाट एवर द वे यू स्क्रू इट इज ओके, बट टाइट इन्फंटिबुलर होल्स इफ यू हैव लार्ज वन डोंट फोर्स. I don't know how large you have, but in small infundibulum, small PUJ, this alkan rod can go sequentially up to upper ureter also you can dilate. It is not sharing effect what you have shown in Katappa. It will cut through everything. You are not going to kill the kidney, Baba. You are not going to kill the kidney and Bahubali. You have to save the kidney and remove the stone, not the aorta, not all these things. Screw slowly if you have large rod to remove big stones. If you have small bore, I mean small rod, it does not matter whether you screw or not. Now you see on the top slide, you may feel very heroic, but tissues feeling with single step dilatation will be like that. But below, if you have some love and affection, slowly if you do dilatation, that will be like this. You want these smiling faces or you want crying faces thinking that you are Katappa. अब तो आ जाओ वापस and screw slowly. Thank you.
Excellent rebuttal, sir. Sir, Sabnis sir, we'd like to learn from you. Can you exactly point out what we mean by single step dilatation in PCNL? Because there are a lot of controversies defining the single step theory in PCNL. So please, Sabnis sir, your point.
Basically, single step is actually a misnomer. When you call a single step, what exactly is mean that you put a puncture needle wire and on that you do a single step dilatation, which nobody does. Balloon dilatation is the only method by which you can reach up to single stage, but those who propagate single stage also do a little limited steps. So basically, when you talk of a single step dilatation, it means that it is not a sequential dilatation as conventionally it is called as, where you put multiple dilators over each other. That's a sequential dilatation. I think that is now not being practiced by majority of the urologists. But when you do even mini PCNL, you do a puncture, put a wire, do a little bit of screw dilatation by 6 to 12 or 6 to 10, something like that, and then you jump from 10 to 15 or 16 like that. So you jump over the dilatation. That is what actually is called as single step dilatation, because you are not threading multiple dilators one by one. And I feel there are all advantages of a minimal step dilatation, so-called single step dilatation, what I described, over the sequential dilatation. What Chandramohan was trying to convince is the sequential dilatation, which I think is now probably given up. And therefore, Chandramohan, if you try to do things very, very slowly and gently, the other people will take away the bread and butter, and then you will left up with doing things slowly only. Thank you.
Yes, sir. So the take-home message by Dr. Sabnis sir is that even though we use a screw dilator, we'll still call it as a single-step dilator only, because the Western literature, they quote with the balloon dilators only, and they directly over the balloon dilators they put the ampulas. Yes, sir. Sir, Madhusudan Agarwal, sir, your say?
You see, you have to differentiate between a mini perk and a conventional size. The most mini perks are either a one-step dilatation or two-step procedures. So the two-step has just been described by Dr. Sabnis. You can railroad or thread the sheath over a screw dilator, and then it becomes a single step. So we often do that. We actually do a single step by putting a screw dilator and sliding the sheath over the screw dilator. So it can be a single step. So in a mini perk, there is no problem in doing a single step. But if you are doing a conventional, which is 24 or 26, then you require to do at least two steps, like Dr. Sabnis said, but you skip the intermediary steps. In the standard Cook implant system, there used to be serial dilators every 2 French. Nobody does that anymore, like he said. But if you are using the Elkin, then you have to use the rods one after the other. Otherwise, you will never reach 24 French. So when an alternative was provided by Dr. Pal, when he was able to indigenously produce the Lame dilator set, which had 4 sheaths. And if you used only up to 24, then you needed only 3. So these are alternatives to reduce the number of steps. They are not strictly single step, but if you have to reach up to 24, then you need more than one step. So Dr. Chandramohan is correct that if you have to dilate to a larger sheath through a narrow infundibulum, you have to be gentle. But if you have to do a mini perk, and now we do almost 70 to 80% of all our perks with a mini perk, then a single step will suffice.
Yes. Well said, sir. Dr. Pal, sir, your last say on the same sequential or single step?
Ultimately, you have decided, seeing the bulk of the stone and seeing the patient's position and the availability of instruments, you have chosen a step, a size of the implant sheath which you are going to use. So Chandramohan, you have a fixed size which you have to put in. Now, whether you put it slowly and go on from increasing it further, or you do in one go, it is just the same thing. The hole in the kidney is going to be the same. Regarding the dilators, I have to say only one thing. If it is a sequential dilator, when you do dilatation, make the hole in the kidney and then remove it. Till the next one comes in, there is a bleeding going on because the hole has been created. And then it is always better, in my view, not to leave it in between. Just do a telescopic dilators. Now telescopic dilators up to the size of 24, you can have only 3 dilators. So one over that other and over that other. The last one has got a implant sheath over that. So otherwise it doesn't make a difference. You have made a size, you have made up a mind, this size of implant sheath, whether you go in one go or you go in 2-3 steps, it is just the same. It is better to use telescopic dilators rather than a sequential dilators to reduce the bleeding, or to use a balloon dilator if you have, if the cost permits. Balloon is also in one go, it will dilate up to that.
I don't think anybody uses it in this country. And they produce only 30 French balloons, Cook Company.
Yeah.
So nobody does it. I've tried it a few times. I don't think it serves any purpose.
The cost is also matter, I guess.
Prohibitive.
Slow screwing or a thick screwing is one and the same thing. You have one size, you know that.
Okay. Very well taken, sir. Thank you, sir. Thank you. So we come to the last session of the debate. I would like to introduce the speakers. We have Dr. Vilas Sable sir from Pune, who is the HOD of DY Patil, Department of Urology. He is very well known for his PCNL skills. And on the other hand, he will be talking with the Amplas sheath. And on the other hand, we have the Elon Musk of India, who keeps on inventing things. Dr. Kaushik Shah sir with his super perk sheath. So I'd like to start the debate with Dr. Vilas Sable sir. Please, sir, share your slides. Hello, Dr. Vilas Sable sir. Am I audible?
Visible? Yeah. Am I visible?
Yes, sir.
Just a second. Everyone, after this common job to do, what size to use. About Amplas sheath, we should know it was introduced by Kurtz Amplas devices. This is the Amplas septal occluder which he has devised. We all know this timeline. It was done way back in 1941. It was 1976 when Firmstan used and we all are aware there are different sizes. Initially, PCNL was conventional PCNL, the smallest, most commonly used by 28 and 30 French, which practically has gone down to less than 10%. We are using smaller and smaller sheets. People have more than 25 French, 20, 22, 25 French, 15 to 20 French, 10 to 15 French, 5 to 10 French, and smaller than that. So there could be various ways to look at it. Amplas sheets. Amplas sheets are firm sheets designed to allow smooth passage of surgical instruments into the kidney dilatation. They are available in different sizes, different colors, but usually the inner layer is a dark color. It is basically PCNL is an extension of a Seldinger technique to have access to the renal collecting system and do intrarenal stone surgery and variety of other intrarenal surgeries. The main features of Amplas sheath: it is firm, kink resistant PTFE material. The surface is smooth. The tapered tip is designed for atraumatic placement and ease of advancement over dilators or balloons. It is radio opaque, though not densely radio opaque, but just to visualize it under CM. They are usually dark color so as to absorb light rather than reflect it. Initially, they were available. The original set of Amplas dilators with sheath was available only beyond 24 centimeter. Now they are available from a smaller size, and the metallic are much smaller also available. The common lengths available are 17 and 20 centimeter Amplas sheets. What an ideal Amplas sheet should be? it is disposable, but I always call in India dispose if able. So it's a different story. Usually they should be soft and pliable. There are people who use hard amplage sheets, which can be traumatic if not used properly. They should not grip. They should not become static while passing through the muscle layers, and they should slide easily. They should be malleable to certain extent whenever odd fragment shape is to be removed. With the availability of a better devices, which you have learned over the last 2 hours, like holmium laser, thulium fiber laser, smaller and smaller amplas with smaller and smaller nephroscopes are being used for PCNL with lot of advantages. This was initial standard 30 French amplas sheet, and we have a ultra mini PCNL of 11 French metallic sheets, and mini perk XS much smaller than that also. This is one study where they are compared the amplage sheet diameter and various complications like blood loss, hospital stay, nephrostomy tube size, and smaller the amplage sheet has proved effective in variety of ways to reduce the blood loss. Then the nephrostomy size also reduces, the hospital stay reduces, but at times for a larger stagon, the larger sheath can be useful to reduce the operative time and get larger fragments much frequently and easily. There are various variants of amplage sheath available. Like conventional sheath, there are split peel-off sheath. There are metallic sheaths, super perk sheath, as my competitor is going to make you wise about. Then some people had bored a hole at the outer end of the sheath, at the cut end of the sheath. So as to allow easy egress of water as well as small. This is the guide wire holding proximal end with a small slit which are manufactured This is a split peel-off sheath. Entries of easily. It has less blood loss. It keeps the intrarenal pressure low, allows visual clarity because of free inflow of and outflow of the irrigation. Obviously, it reduces intrarenal pressure and the chances of extravasation. Stone fragments can be picked up easily when you are using larger sheets, and with a smaller sheet, there is a whirlpool effect which has been popularized by Karl Stoss, wherein the dust keeps on coming by the side.
Sir, your internet is unstable, sir.
About it can get
I think Vilas sir, internet is unstable. Can you start with Kaushik sir presentation?
Hello.
Hello, sir. Can you start? I think his internet is unstable.
I'll start my presentation if you say so.
Yes, sir. Please, sir.
Okay.
Hello. Can you hear me?
Yes. Can you hear me? Hello.
Yes, sir.
Yes, sir.
Yes, sir.
Yes, sir. Please go ahead, sir.
Good afternoon. I thank the Elot Group, Starpark, and the stalwart like Dr. Sabnis, Dr. Madhu, Dr. Pal for giving me this opportunity. And I'm happy that my sheet is being compared with the world standard employer sheet. But the change is the only constant thing in the life. Are you able to hear me? Hello?
Yes, sir. Please go ahead, sir.
The disruptive change in the Emplas sheath was needed and it is being fulfilled by Shah sheath. We all have used this Emplas sheath, and the new sheath that is available is a Shah sheath. See, I grew up using Emplas sheath over decades. It has worked wonders, but there are problems with Emplas sheath. And as the world started shifting to a small crack size PCNL, changes in the design of the sheath became inevitable, but it still needed a disruptive change to add a suction in a sheath, and that is fulfilled by my sheath. The problem of Emplas sheath is that it has an oblique tip, and therefore the vision at the entry of calyx is difficult, because if it is pulled at the end, the bleeding and extravasation occurs. Though it is disposable, in a developing countries, it is used repeatedly with the torn out edges, leading to damage to the kidney and the bleeding. The use of suction is cumbersome, time consuming, interrupting the lithotripsy, is not very effective, and associated with frequent blockage of suction channel. For mini PCNL, it has already been replaced by other sheets. So the question was, can we reduce these problems like stone migration, pick up the stone fragments by grasper, residual stone fragments and dust, spillage of water on table, intrarenal pressure, dust obscuring vision during lithotripsy, as Dr. Sabnis suggested. We need a quick and complete clearance of stegon, collection of stone fragments, and many other problems. So what is the Shah sheath? It's basically a renal sheath designed to be used as a sheath with suction for superpoc. It has taken away the burden of stone fragment removal from the nephroscope and the lithotripsy devices. It allows the nephroscope and the lithotripsy probe to be thinner. It's useful in all forms of PCNL, even if you are not doing superpoc. It is modular in design and is a value-added services over Emplas sheath. Depending upon how many modules you add, you get an ease in doing PCNL. It's lightweight, reusable, autoclavable, and long-lasting. This is a Shah sheath. I would redesign and redefine the role. This sheath has come with a dedicated dilators. This is a suction master to add the suction. This is a connector to adapt to the different size of the nephroscope to give an airtight seal. This is a low pressure suction machine with a tap on the suction bottle to empty it easily. And this is a stone catcher bottle to collect the stone fragments. So these are the equipment that we use. See, the different sizes of the sheath available from 12 to 24, and the different connectors are to use depending upon the size of the nephroscope you use. So there is a huge versatility in using this sheath. So when you are doing a PCNL, instead of using an Emplas sheath, you just have to replace the Shah sheath. And that is the air opening here, and the fluid outlet is connected by a suction tube to the suction machine via stone catcher bottle. So when the suction is on and this air opening is also on, all the fluid and fragments is being continually sucked. And if the air opening is open, the suction pressure inside the system is minimal. Water, fluid, and fragments are coming into the suction chamber, is being sucked out along with the air, and therefore there is a big control on the suction machine. This is called superpoc system. Now, if you use the only first part, this is the first part, it is same like any mini PCNL sheath or Emplas sheath. So if you use the Shah sheath, there are all the advantages of Emplas sheath and there are no disadvantages of Emplas sheath. I'll narrate what are the disadvantages. See, when you are using an Emplas sheath, there is a lot of spillage of water. But if you just connect the tube, practically there is no spillage of water and no chance of hypothermia, messy operative field. If you use a connector, in and out movement of the nephroscope is very easy. When the fragment comes here, automatically fragments will come out from here and you don't have to take out the nephroscope every time. So you save a lot of time. It's ergonomically easy. When you are doing like Dr. Chandramohan is doing supine PCNL or many, when you close both the opening, the system distance, and therefore it is very good when in supine PCNL the system collapses. It is also very good at the end of a nephroscopy, lithotripsy,
that you can see all calyces because it opens up all the calyceal opening and we can see everything. And when you use a full system, the suction is available and it helps in ease, speed, safe efficacy and safety of fragments removal. As Dr. Kukreja has rightly pointed out, it is the speed of fragmentation and the fragment removal that is very important. And here you can use a pneumatic or a laser and the fragment removal time is much shorter and we can do procedure faster. The suction management is very easy. All what you have to do is put a stone catcher bottle and connect the two tubes. That is all what you require. And the rest of the things are very easy. So you can see here that the stone, you need to grasp every small fragments. Here, if you apply suction, all the fragment comes out very easily. You don't need to search for the fragments. Fragment search is for the end of the sheet to come out. So practically no graspers is required in shower sheet. Again, as mentioned, there is no spillage of water in a shower sheet. No fragments are required to be collected. Separate attempt need not be done. Automatically, all the fragment comes into the suction bottle. And at the end of a procedure, we can show to the patient. We can send it for the laboratory analysis and everything. There is no bending of the sheath because it is a metal sheath. Even if you go through the intercostal space, there is no buckling, and if you move, that doesn't break the nephroscope, and it is very easy to take out the fragments. And you can do a stegon stone with a faster clearance with a smaller track. Here, with a 21 French chassis, the whole procedure was completed within an hour. That is a big advantage for a stegon stones also. The salient advantage of chassis is it's very easy to introduce. It is a one-step dilatation with a seed insertion, the way Dr. Madhu Agarwal has mentioned. It reduces the operating time and the radiation exposure. There are minimal chances of opposite wall perforation, ergonomic to handle the sheet, and the small sheet like 15, 12, 18 are very sturdy, and it has replaced the other mini PCNL sheets. And it is very useful in multi-track PCNL. All the subsequent track can be only 12 or 15 French. And track size more than 24 is not needed, even if you want to use the shock pulse lithotripsy. And therefore, the advantage of a small track is available even for the biggest stone. To summarize, the advantage of chassis over amplasses are many. It gives clearer fill during fragmentation. Practically no forceps is required for majority of the cases. It reduces the fragmentation time. Dusting approach is not required. You can complete pneumatic or a laser, whatever energy you want to use, you can use. Very big fragments can be retrieved without use of forceps. It reduces the stone migration rate. It improves the surgeon's comfort, reduces the nephroscopy time. It gives better clearance. And most important, it reduces the infective complications. So the change is difficult, but not changing is fatal. I invite everyone to adopt a new sheet. That is going to be a big boon. Thank you.
Over to Vilas Sable sir. Shah sir, please stop sharing so that Dr. Sable sir will share. Dr. Vilas
Yes.
sir.
Yeah, am I audible?
Yes, sir. Yes, sir.
Yes. Can you see my presentation?
Not yet.
One sec, just one sec. Yeah, I'll just start from where I left.
Yes, sir.
The disadvantages of Teflon sheets. Teflon sheet, the beveled end can be traumatic and can abrade narrow areas, narrow infundibuli, and even the thinned out parenchyma also. Similarly, in a redo cases where there is a fibrosis or when you are going in an intercostal punctures, the bevel tip can get traumatized and the ragged tip can again create renal trauma and associated bleeding. So one has to be careful about it. With intercostal puncture, the sheath can bend and making our entry of nephroscope and other instruments little more tedious because it is malleable. At times, again in a redo cases, your amplas sheath can override and create a cross perforation. One has to be really beware about it. With serious telescoping metal dilators, they are available with a difference of alkane dilators, what Dr. Chandramohan was talking, they are available with a difference of 3 French each. 9, 12, 15, and you do not have ampla sheets exactly corresponding to that. So at time it can core out a ring biopsy of the kidney. Similarly, about metallic sheets, larger metallic sheets are not in use. Again, for the same reason, it can create a trauma. They are used usually for single puncture, mini perc, and single step dilators, and they can create a increase in intrarenal pressure because of a closed system, where this means super perc can be helpful. Thank you. I think I'll go ahead with rebuttal also now once I have heard Dr. Kaushik Bhai. Is that okay?
Yes, sir. Yes, sir. Please go ahead.
Yeah.
Yes, sir. Please do that, sir.
Yeah.
Yes, sir. Yes.
Basically, we are, as far as searching for references of use for ampla sheets, one cannot imagine a PCNL without ampla sheets. So whatever I had got a reference is for different changes or different available modifications. As Dr. Kaushik Bhai stated, the only constant in the universe is the change. But most modifications are made on individual preferences and according to the surgeon's comfort and dexterity. Everybody is not lucky to have the same brand as Kaushik Bhai or the seniority or the volume. These modifications have to stand the test of time before they become gold standard. The mirror, ordinary mirror, will show you exactly what you are. We have a lot of distorted mirrors where a short dwarf can get converted into Amitabh Bachchan within no time, and a lanky fellow can get converted into Superman. But these have to become conventionally accepted. This modification should stay with test of time. Similarly, while driving, one should not start with to become an Air Force pilot with a supersonic jets. So during PCNL, as I am a hardcore teacher for years, I will like to have a safe PCNL surgeon in the beginning, where they should learn the basic techniques using the conventional scopes, and everybody must be experienced. I just saw how many additional tubings and suction bottle, the collector bottle and suction machine. Everybody is not lucky to have that setup. Many of the places where PCNLs are being done, many people do not know how to give position, and we have to bother about whether glycine is going instead of normal saline. So in these circumstances, before trying for newer and fancy ideas, one should get acquainted to the conventional ampla sheets, conventional systems, and then they can add on. Otherwise, leave it to the experts like Kaushik Bhai. Thank you. Meanwhile, enjoy the COVID warriorship. That me in a OPD setup.
Excellent rebuttal. Kaushik sir, you please go ahead.
Stop.
Sir, you have to stop your slide.
Yeah.
I'll share my screen. Thank you, Dr. Vilas. I mean, it is not required to be an expert. It is required to be more lenient in spending few thousands of rupees. Then you can immediately switch over from ampla sheet to SHAR sheet. It is much more economical, viable for these things. So if you want to use an ampla sheet, 24 French sheet for Stegoni's recent edition, many of you find that suction is not available, it is cumbersome. But what is important is that if you follow the SOP, if you spend few cases to learn PCNL and learn this technique, all these problems will not arise. It is one of the most easy surgery. In fact, it would make the PCNL surgery much easier because there is a lot of problems which if you use an ampla sheet, you have to pick up the fragments, you have to control the things. None of these things. So it makes the PCNL much easy if you start using a SHAR sheet. So if you follow the SOP, problems will not be there. All what you need is buy a suction machine, which is a low pressure suction machine, dedicated machine. It doesn't cost more than 10,000 rupees. This is coming along with the sheet. So practically, it can be available in the remotest area. It is very lightweight. It is transportable. and the suction bottle is such that just open the tap and it would empty immediately. So it becomes a ease for the staff and the people around. And if you follow, see, change is inevitable. Things are going to come. It depends on us whether we want to progress. It's a choice. If you want to change, then there is a chance. So when we want to change and grow, we'll see a world we never know. We'll not realize that it was so easy. Every one of us, those who have started using, it has become an addiction for them to use a star sheet. So, dear friends, secret of change is not to focus energy on fighting for the old, but spend your energy on building something new. A lot of new things today's debate has brought on us, and we'll try to focus on what is possible with the new things. Thank you.
Excellent presentation, both the speakers. So we come to the end of the session. Dr. Madhu sir, your final say on the Ampla sheet and the Shah sheet, your experience, please.
Well, friends, both the speakers have done a great job. Dr. Vilas has highlighted a lot of good things about Amplads and Amplad sheath. And I'm sure many of us were not aware that Amplads was actually a radiologist and that he had so many non-urological things also to his credit. But yes, Amplad sheath is something that we all grew up with, and you cannot imagine doing surgery, PCNL without Amplad sheath. And you can look at all other future sheets as just a modification of the Amplads. So Kaushik Bhai's contribution is an outstanding addition of suction. It's a, I would say, a quantum jump, a breakthrough in converting an open drainage system into a closed drainage system, and addition of suction to the sheath. And I have the pleasure of having worked with him right from the beginning. And I don't know why Kaushik Bhai didn't show us the publication that was made. We got it published, the first publication on Super Perk. So now it has become popular all over the country. And I think it is an outstanding piece of engineering and science, where we have converted an open drainage system into a closed drainage system and retaining all the benefits of the Amplad sheath and adding so many more. And today I cannot imagine doing a PCNL without this system. Interestingly, I have also worked with Zeng, who developed an almost identical system at the same time. So it's how great minds work. Zeng was doing exactly the same thing in China at the same time, and he developed, and even he called it very similar, Super Mini Perk. He calls it SMP, and I worked with him and published with him also. We did a multi-centric international study showing how a Super Mini Perk helps. And now all over the world, addition of suction to the sheath has become a standardized thing. And the design which Zeng had developed is now being used in Europe also widely. So I think this is a new development, a progress which is going to stay.
Thank you, sir. With your support, I could achieve so much. You, Dr. Sabnis, Dr. Mahesh Bhai.
No, great.
Sabnis sir, your say.
Yes, I think both presentations were very good. They proved their points. What the changes which have happened in last 3 decades or so, that the suction now has become a very important thing. Suddenly, in last maybe 5 or 6 years or so, everybody has realized the value of suction. Now, when we talk of a mini PCNL size, I mean mini perk size and the large size, I still feel that open system with the Amplads and with the bigger scope will do the job well. But when it comes to the smaller size sheet, I think that is where the debate is happening. That is where the benefits of all this suction and this thing is coming. And I think Kaushik has highlighted the advantages of a sheath where the suction helps in getting the fragments out. But I feel there are two things now which are going to happen. The suction, everybody all over the world have realized that suction is a very, very important thing. However, suction, whether it should be on the sheath or suction, whether it should be on the probe, that is a point which is going to be a deciding factor for the future, because now the shock pulse, the triology, all of them have come with the mini perk size sheets, and they are also becoming very widely popular. And if you use that, whether the suction on the sheath is needed or not, whether the vacuum cleaner effect, which Nagle and group still believes, and they have their own science, they have their own publications with their own thing, whether it really suction is required or not, that debate will continue. But I think this is the very, very important development which has taken place, and we all should be proud that one of the development is done by our own friend urologist, and we are all thank him for this development which has taken place. Thank you.
Yes, sir. Thank you, sir. Pal, sir.
Thank you, sir.
Your say, please.
Thank you very much to all of you for giving me this opportunity. Actually, amplard sheath, why it has a oblique beak? There is a reason. When we are going through the tissues, there is a thick lumbodorsal fascia, capsule, renal capsule, and sometimes if it is a fibro, earlier surgery has been done, if you go through, there will be fibrous tissue. So when you rotate the amplard sheath with the oblique beak, it easily finds the way, it doesn't core out the biopsy tissue, and it easily enter inside the kidney. Secondly, when you are inside the kidney and if there is a bleeding from one area, maybe one side of the circumference, if you rotate the amplard sheath in such a way that that area gets tamponade, you have a further good space without bleeding to work into. So that is the reason why amplard sheath has a cut end. At the same time, other end of the amplard sheath is straight, like our Shah's sheath. So if you want to use a straight end, if it is a soft tissue, if it is a not much fibrosis, you can always use the amplard sheath other way around and put the round sheath inside. Nothing prevents you to work like this. So amplard sheath is that way very versatile from both the ways. With due all regards to Dr. Kaushik as well as to Dr. Zeng, the basic concept of this plastic sheath with the suction is way old, was 2008 when Dr. Wan in China invented this. I have worked with him and he gave me 5 of these sheets with the suction and the bottle like what Dr. Shah has shown now. I have used it, and from 2008 to 2010 for 2 years, this Wan sheath was being used extensively in China. Somehow it did not get popularized because they were always using thin amplard sheath, means thinner tubes. And again, suction was a difficult thing to manage. Now also, if I feel it is a very useful, Shah sheath is very useful if you have to have the amplard sheath of smaller size so that suction keeps the pressure low inside. During PCNL, low pressure is a must. But if you are not very shy to increase the size by another 2 French, and there is a difference of 4 French between the size of nephroscope and the amplard sheath, because kidney is not a very huge place. Whatever fluid will come out, it automatically comes out if there is a 4 French gap between the nephroscope and the amplard sheath. It's a good invention, particularly for the smaller, for mini nephroscope with the instruments with the smaller size to maintain a low suction. But suction has to be nicely regulated so that it doesn't collapse. The system does not collapse and you have to have a good vision inside. So this is how amplard sheath also has a role with the oblique beak, as well as the Shah sheath also has a very good role for the smaller size. That is my take for the sheath. Thank you. Thanks for listening.
Thank you.
Thank you, sir.
Thank
you.
So
before
everyone.
we conclude, we'll have closing remarks from all 3 experts. Sabnis, sir.
I think this was the excellent debate. The topics chosen were of a real great relevance, not only from the theory point of view, but from the practical point of view. And that's the reason probably we have really gone overboard. But nevertheless, this time was very well spent. See, what happens is that in debates, all the speakers take the extreme position, even though in their own mind they know that this is not a correct thing. But in a debate, you have to speak aggressively for one side, and that everybody knows. But the benefit of this extreme position is that the audience, they know everything, the plus and minus point, extreme points of both the topics. And therefore, I think this debate was of a great relevance. All the topics were very well chosen. And I must congratulate Dr. Jain and all other Ulto team for the excellent session today morning. Thank you.
Thank you.
Madhu sir, your closing remarks, please.
Well, friends, thanks first of all for giving this opportunity to be with you. And thank you, the Alto team and the Star Perks and all friends for this excellent program. I think the most important thing is that almost every aspect of PCNL was covered threadbare through these very interesting 6 debates. And like Dr. Sabnis said, all important points of every aspect were highlighted through the for and against debates. So I think it came out wonderfully well. And except that we should have probably kept to the time more strictly, it went off very well. Excellent. So I congratulate all the participants and thank all the people who attended and listened to our debate. Thank you very much.
Sorry, sir, for exceeding the time. We'll try to manage in the next. Pal, sir.
It's all right.
See, one of the surgeries like hernia, as many surgeons, as many techniques. Similarly, PCNL has got so much variables. Every step is debatable. Every step can be done in a different way. And when you put 20 steps of the PCNL together, there will be 20 debates coming out of it. So it is always better to put your mind into it, listen to different people, and then make up your own technique, which you feel best. One step from here, one step from there will really make you perfect in whatever way you want to do. So it is good that such debate was opened up. Thank you very much. Thanks to Nitin, thanks to Harsh, thanks to Nitesh and the other members of the Ulto team for arranging such a beautiful seminar debate topic. And thanks to all the listeners who have been listening to us. Thank you very much. All the best. Enjoy.
Any of the speaker want to say anything? Chandramohan sir?
Yeah, well conducted, crisp. 7 to 8 minutes is a good time, and the seniors have commented very well. Definitely, there is a lot of learning today. After a long time, I have not gone even 1 minute outside. It was thoroughly, I was thoroughly enjoying. Thank you, Nitesh and Harsha, for giving this opportunity. Great.
Yeah, absolutely.
Anyone else?
Yeah, thank you,
Excellent
Nitesh.
opportunity to present, and it was a great learning thing for us also, that so many different aspects came up, and it refreshed all what we knew before.
I'd like to say thank you also. This is a very humbling experience being one of you guys. I really feel I'm really one of you right now. Thank you so much again for the opportunity. And I hope I will be able to travel again and see all of you in one sitting personally. Take care. Take care.
Yeah, we all specially thank Dr. Madhu sir, Dr. Sabnis sir and Dr. Pal sir for dedicating so much of time for this debate, and we are all thankful for them, senior people like you commenting here. And you know, your time is so important. We can understand you have got so many liabilities and so much of things to do, but it's really appreciable that senior faculties like you coming here, giving tips and advising is very nice. Thank you the mentors. We are very nice of you.
So thanks, Hermi. It's good to see you, and thank you for staying with us all through. And
thank you, everyone. I thank you one and all on behalf of Team Ulte and Starper for excellent debates and rebuttal. And it was a really great interactive session. Very nice word of wisdom from our expert. It was nice to have all the stalwarts from the field of PCNL on FB Ulte platform. Sorry, we are not able to do it live on Ulte, but we are able to stream it on YouTube channel. Shortly, I will upload the entire program on Facebook as well.
Dr. Vilas sir has to say something. I guess he is waiting there.
Out best speaker for the talk. I request all to be part of Ulte family and guide us through the journey of learning and spreading knowledge. Thank you once again. Thank you.
Thank you.
Sir, Vilas sir is about to say something. Is there waiting? Yes, sir. Please go ahead.
It is really nice to have three important stalwarts, three figures from who we kept on learning PCNL. Dr. Sabnis was my first guru in urology. And what we, once it comes to PCNL, we have been quoting Dr. Pal sir all along. To have them face 1:1 for each and every point was a really good thing. I am thankful to Alto as well as Dr. Harshawardhan and Tanwar for giving us excellent opportunity. Overall, it was excellent.
Yes, sir. So thank you all of you. Have a great day and have safe COVID period because I know it's going to be tough times ahead. See you, everyone.
Well, thank you, Harshawardhan and team.
Aren't we going to get a picture, Harsha?
Yeah, sure. Why not? Nitesh sir, please click a picture together, all of us. The Starbucks team.
Harsha, I hope you are still on hotspot.
No, sir. Sir, we are still on the hotspot only. I've just mobilized a remdesivir right from Pune to my brother-in-law who is severely affected. I'm taking care of him in my own hospital.
Right.
I have sent remdesivir from Chennai to Delhi.
It's horrible. It's getting worse.
The situation is quite grim actually.
Take care.
Yes, sir. Okay. See you then, sir.
Okay.
Everyone.
See you. Thank you. Bye-bye.
Bye-bye.
Thank you.